not to share their data. And I think we remember very well that some countries did not share their data. But now it will be obligatory. The problem is that when you share this data, sometimes it can be weaponized against you, like we saw during the COVID pandemic. When the Omicron variant came up, there was an attempt to lock out a certain part of the world. So we are also looking at how we can make sure that our data is secure. We know that this data will accrue a lot of benefits when we share it, and we are trying to see how we can participate in discussions to ensure that these benefits also trickle to us. Sharing of data comes with sharing of samples and pathogens, the ones that are causing disease. We are also looking at issues of increasing our local production capacity for countermeasures, not just vaccines, but even other therapeutics, other health products and technologies, and even other supplies like medical oxygen, equipment, and that we can talk about a whole discussion around the new paradigm shift that we have undertaken when our president recently launched the UHC program in Kenya just last month, and it takes care of a lot of the things that we are talking about. And finally, we are also looking at how we can participate very effectively in the discussion around establishing a platform that ensures equity. Because in the short term, if we are hit by a pandemic today, we will definitely want to have measures that ensure that the countermeasures, vaccines, medicines, and all the others, medical know-how, is available to all the countries equitably, whether it is from the global north, global south, or anywhere. But in the long term, we are also looking at how we can be able to ensure that there is tech transfer strategically to enable us to produce our own countermeasures. Thank you, and back to you.
Thanks a lot. We'll get a little bit deeper into the technology transfer, but also you mentioned about the interest in the Kenyan government to really invest and allocate money to the health sector to prepare you much better. Let's go to Uganda and speak to Dr. Daniel here. Dr. Dan, you sit at the top management team at the Ministry of Health, and indeed, you're one of the teams that oversees the entire country's health. How far have you reached in terms of implementation of some of the commitments that were made by government of Uganda during the pandemic in terms of preparing us better?
Thank you very much. My name is Daniel Chabainze. I am privileged and honored to be part of the leadership team. And I now critically see that without proper leadership, all these other things we are talking about to put in place the commitments will fall through the cracks. A point in time is that after the COVID pandemic, Uganda was unfortunate to experience an Ebola outbreak. So all the things we had said we are putting in place were quickly brought into test. Because when the Ebola broke out and it actually reached the main city, the capital city, it was time to see what are the things that we have learned during the COVID pandemic being put in play. So that, first of all, based on what we have agreement never to make sure that diseases spill over borders, because it cannot become a pandemic unless the epidemic spills out of your border to the next country. And we saw that it's all about being thoughtful as leaders and being so resolute that you take decisions which are very unpopular but give you the results. In 69 days, Uganda cut out the transmission of Ebola in the country. And it was a success story. We are marveled about how that was achieved. We made commitments about oxygen. For instance, Uganda sponsored the WHO resolution to make oxygen one of the essential medicines. And that is what we took on the policy level to contribute to what we're seeing. As you mentioned, you see your loved one looking for oxygen because then oxygen became the main therapy. Previously, oxygen was thought for those who are tail end of their lives. Now it's part of therapy. You can actually have oxygen therapy right in your home. We have come up with strategic leadership levels and coordination that keeps themselves in check. We have recently concluded our joint external evaluation, which is a paramount requirement that for you to check how your system is ready and they're able to rank yourself based on how you've performed during the previous actions, because after action review is very important for you to know how you are progressing towards the commitments you've done. So as Uganda, we've been able to successfully have that evaluation, and we saw in that evaluation that as a country, our strongest pillar is a response to epidemic and pandemic threats in the country. Not because of the many countermeasures that we have. No, it's because of the resolute of the leaders to use whatever options they have on the table at the time of the epidemics. And the epidemics will happen, and God forbid that they can become pandemics, and nobody is prepared. Just to flip back and let you know, when COVID broke, there were no technical advisors flown to our countries. We had to handle our issues. Nobody came to Kenya, nobody came to Uganda, because we all had the same problem. So the internal capacity, the internal scientist, the internal preparedness and whatever resources you had is what you had to be. While you are listening, social listening in what is happening elsewhere, then you prepare. So we also have to know that we must be teachable. We are quickly agile and adaptive to make sure we are learning from what we hear elsewhere, as long as and as well as countering the misinformation which was coming. So in a nutshell, Uganda has been able to experience, first of all, the pandemic, COVID, struck the countries, but Uganda felt it was resilient enough to handle what happened. But then it was quickly tested and demonstrated that, yes, we have had some learnings. And now we are actually continuously learning, because at the time we had the COVID outbreak in 2020, Uganda had just finished a simulation exercise just in case there is an outbreak, because we were watching an Ebola outbreak in Congo. We are on alert so that when COVID broke out, we are able to use the incident management approach so that we can able to understand and respond. And it's a very well-known approach. It needs to be tested. We cannot be only in simulation, but once it kicks into action, that's when you can learn the gaps that we had. And there are many gaps, but I'm happy to share that we have been able to learn and adapt and unlearn the things we didn't know. Because people will say, oh, you were so excessive, you were so aggressive, you were so extreme in your ideas. We are unlearning because there are many things we didn't know about a particular disease. The beauty with epidemiology is that you can see that everything comes uniquely, and if you can't adapt, then you'll use measures which are required for COVID in Ebola or in Ebola in COVID, because you need to understand the pathophysiology. How is this disease spread? How is it different? And what things do you adapt from other disease patterns that you can employ? But you can't take everything wholesome because we did this previously, that's why we're doing this. No, you need to continuously learn and adapt and unlearn. The unlearning is the very difficult part of this exercise.
All right. We're hopeful that we will relearn and unlearn. Dr. Daniel, thank you. We'll get more specific in the second phase, but let me just bring in Dr. Atela here, who represents the medical practitioners who are on the front line every single time. Really, let's just clap for our medical workers across Africa who risked their lives, gave it all to ensure that they save lives. They worked shift after shift after shift. What we see, however, across the continent are consistent strikes of medical workers that they are not catered for. We've had strikes in Kenya, we've had strikes in Uganda, we've had strikes in West Africa, Nigeria, Malawi, everywhere. At least I had a Twitter space about 3 weeks ago where different medical associations were all saying, you know, they don't care about us, and yet we are on the front line. COVID taught us a lot, that medical workers are very central to our health systems. Do you think that governments in Africa, and specifically perhaps in Kenya, are really taking the medical workforce seriously as we continue to strengthen our systems for future pandemics?
Yeah, thank you so much. I think the legacy of COVID-19 should not be that of disruptions and disparity across Africa and globally, but it should be that which is meant to strengthen the monuments of healthcare. And if we look back into the tone of conversations that many African countries undertake, that they would really deliver in terms of the health workforce, in terms of the protections of the workers, in terms of the provisions of the commodities, vis-a-vis what is actually happening in those facilities that is quite dreadful. And I will start by saying that what really, COVID-19, what did the health workers experience? These are situations whereby there is a virus and nobody understands it, and then you're in the front line to go and actually offer the services. And we used to say, and we keep on saying this, that most of the health workers across Africa, and mostly because of the lack of the PPEs and because of the nature of the working environment, were actually going to work not in the mission to protect lives, but also the mission to themselves get infected, because the countries were not prepared at that particular time. And I remember in Kenya, particularly in 2020, we had to actually issue a strike notice to the government for them to prioritize the need to invest and buy the protective equipment for the health workforce. But then there was also this element of the shortage. You realize that at that particular time of the COVID-19, there was a thronging of different people to the hospitals because the focus was on the COVID-19. But then there was a big shortage of health workforce. We were having situations whereby you will be in the hospitals and you know that a patient who has come in can actually be the deaths of particular patients can be protected and prevented if we have the oxygens, if we have the emergency medications, but those were not in existence. So that was the horrific experience that these health workers were experiencing at this time. And also from these hospitals, they were going home knowing very well that they didn't, because there was less understanding of this COVID-19. So there was part of their family, the families that they would also be infected in this process. Because in the system that we are in Africa, there was no much psychological support that these health workers needed for this process. But how has African countries, Kenya particularly, or even Uganda and others, reacted after this particular COVID-19? We have seen a situation whereby at that point of COVID-19, most of the countries and most of the counties in places like Kenya, where we have healthcare being devolved, there was a strong aspect of blame games, where the national government will come strongly blaming the county government on certain issues. And also this was well experienced in the countries like Nigeria, whereby nobody is taking the responsibility, the duty bearer of the actions that are happening in those particular places. That was coming out very strongly. We were seeing the situation of most countries were reacting to set up what we call the ICU centers. But then immediately that there was the WHO announced the end to COVID-19. If you go to the same institutions now or the same counties, you won't get the same services of the ICUs. These are the situations that have been there. We have had a situation whereby, I will call it actually a paradox, where the number of health workforce across Africa, there's a big shortage. In fact, the WHO investment charter of 2023 was indicating that Africa needs about 6 million health workforce. But then the aspect of them, do we have those who have graduated? You realize that the health workers in cross-cutter, the doctors, the nurses, the clinicians that have graduated over every year actually increasing. But then the countries have not put any particular finances to invest and employ this to serve the communities. And therefore there's a bigger shift in the migration of the workers from the global south, from African countries to these developed countries. And it is quite indicated that as much as we need more health workforce and we have those who have graduated in the country, there are more that are leaving. And what have countries resorted to? We see in Kenya there's a policy that wants to retain the same unemployed health workforce within the country. We have seen a situation in Nigeria where they have now put up a policy where you have to be retained unemployed in the country for 5 years. And therefore, you see, for us to really have a very strong framework for prevention and for preparedness against the pandemic, we must strongly invest in the health workforce and actually have them motivated. Because most of the time when they participate in the industrial actions, it's not because they don't have the job, it's because they're not capacitated, they're not supported to actually deliver those services. So these are very critical components that needs to be there. There's also something that was experienced a lot within the pandemic, and as KMPDU, we also did a very strong project on it, whereby this aspect of misinformation and disinformation on the vaccines, we're seeing a lot of advocacy and plan for independent manufacturing within the African continent. But on the flip side, there's no strong engagement to empower the community to understand the need to be vaccinated. So I think if there was a ground-up approach to it, where we have the community workers engaged to understand and then to educate the public on the vaccines, we have the health workers and make them understand the vaccines, so that even if the countries, African countries, manufacture these vaccines, there's a lot of demystifying the understanding of it, and therefore the uptake will then be realized. This is not for only the COVID-19, but for any other pandemics that may occur. That is very critical.
Thanks. Thank you very much. Thank you very much, Dr. Atela. You're quite passionate there, talking about how we have medical workers. And this is very true, including in Uganda. We have so many doctors graduated, but they're not absorbed into the workforce. I think that's what you're saying. And we also saw the challenges of access to medical equipment. There's nothing that hurts us being a professional, and you don't have tools to be able to do the work. Ask any journalist, television journalist in this room that they sent to a press conference without a camera and just go with a notebook. They would just feel so terrible. I can see my colleagues there smiling. That's the same thing. Let me go to the academia here. Professor Shem, it's good to have you on the panel today. Yours is a voice of reason to the leaders, the academia, and indeed those in the spaces are supposed to really call out these governments because they listen to you. You're supposed to publish papers and call them out and lead conversation and to remind African leaders of their commitments. Are you doing that? And is it bearing fruit, or do we just keep it to the classroom?
Thank you very much. And for this panel, it's a very balanced panel because we have the government, we have academia, and we have the practitioners. We have both duty bearers and right bearers in this room. Now, most of the time, the academia, the government, and the practitioner on the other side speak at cross purpose. I want to illustrate one point and look at it through different lenses. In June, July this year, a female medical doctor died in Nigeria. She was in a lift in the hospital, and the lift plunged down, and she died. This was reported even within the World Bank and the part. While she was found in the lift, if there was enough oxygen in that hospital, she would have been saved. She wasn't saved. And report says that she was a very hardworking personnel. Now, is African prepared? Let us look at the situation along three lenses. One, access, affordability, and equity. Then also bring in the perspective of the governance indicators that we desire in Africa for us to have better outcomes in health. We have voice accountability. Do we speak and negotiate and discuss with governments in Africa? We have government effectiveness. Are our governments effective? We have rule of law. Do we obey the national laws and also our international commitments? Then control of corruption. How well do we control corruption? Then the last one, if all these are taken care of, there is the political stability and absence of violence. Now, let us discuss why this female doctor died. And that was after COVID. First, effectiveness, regulatory quality. If this lift had been serviced properly, this doctor wouldn't have died. If there was oxygen in the hospital, this doctor's life would have been saved. Now, if you look at, this is not just happening in Nigeria, it's happening across Africa. Let us come home to Kenya. One, we did an assessment on health facilities where COVID patients were being tested and managed. Let me just pick one example, Lake Region Economic Bloc. We only found out that only county referral hospitals could test and manage patients. But earlier on, just before they had that capacity, nationally, we did not have the testing capacity of COVID. We used to take samples to South Africa and wait. Now, in those hospitals, which is like a microcosm of Africa, we saw major challenges. One was testing capacity. Counties had a testing quota where they could test only 20 samples per day, like they came using PCR test. So if you have more than 20, you have exceeded your quota. Two, turnaround time, 24 hours. If a medical practitioner has a patient for whom he must make a very rapid decision on the management, they have to wait for 24 hours, during which time this patient is released in the community, increasing, fueling infections within the community. Then the issue of the commodities, the antivirals, the vaccines, the PPEs, they were not there. If they were there, they were very, very few. Control of corruption. It was during that time that we had the COVID billionaires alleged, and the medical workers here, some of them lacked even PPEs. Now you see how governance and outcomes influence governance and in this other aspect influence the outcome of people's well-being. Now, if we talk about access to commodities, for us to access commodities, we must produce them locally. Why can't we produce them locally? One, we have trade barriers. Heavy taxation, even investors are not incentivized to ensure that they establish some local manufacturing in the country. Two, logistics. We are not in control of logistics. Where logistics is means of transporting all these commodities, let's say vaccine in all those tonnage, then storage in the required conditions, temperature and otherwise. If you look at all this, yes, we have gaps. Recent assessment shows deterioration, because if you look at the pandemic accord, it says that we should work to ensure that some of these temporary, really scaled up capabilities we should have to ensure that they are permanent now. Go to our facilities where oxygen was installed, thanks to the national collaboration with the national and national government and the World Bank. Those oxygen plants, there are two aspects of having sufficient oxygen. One is having a bulk tank. Two is having oxygen production plant. these concentrators cannot serve patients that need high flow oxygen. All these facilities, at least in LREB, except Kisumu, Kisii, and Siaya, all of them have broken down.
Professor Shem, you can just as you wrap up, you can bring the mic closer so that we can get the audio.
Okay.
Yes, as you wrap up.
Okay, so all the capabilities that were scaled up during COVID have deteriorated. The oxygen plants have been overwhelmed. How do they get overwhelmed? They take too long to be serviced within the counties. And what happens in those oxygen plants is that the compressor gets overwhelmed because demand is too high. It needs servicing every other time. And it should be supplemented with a bulk tank to ensure that while it's resting or recharging, the bulk tank is being used. That has gone for every other aspect that was increased. Finally, allow me to talk about the very last bit, the human resource. We conducted some assessment with NACOSTI on health workers detecting infectious diseases and budgeting. We found out that however much you improve the facilities, you try to renovate and build new ones, buy equipment and everything, if you don't take care of the medical staff, the health workers, there is reduced detection of infectious diseases. We found out that a unit increase in recurrent expenditure of health, this is the expenditure that goes into payment of health workers, increases detection of infectious diseases. We found that improvement in health facilities actually slightly reduces detection of infectious disease. We asked ourselves, why? We found out that, for example, in 2017, medical practitioners in my country went on strike 216 times. It was either a go-slow, they are on strike. So it is the medical workers that use the microscopes that you buy with development expenditure. So let us take care of health workers to avoid the flight that we are currently witnessing among the nurses that are going to Europe, leaving us bankrupt of trained medical practitioners. Thank you.
All right, thanks. Professor, I just want to give you an extra 30 seconds. I mean, you've done these studies, really. You've gone there, done this research. Have you presented it to the people in power who are supposed to actually take this research seriously and implement on the recommendations that are in those studies that you do? And what has been the response?
I want to give examples. And with COVID, we issued 20 advisories and 6 policy briefs. Most of these were well taken care of and were captured by the media. We really applaud the media, especially the national media group. One of which, when we realized, when Omicron came, that, and we had done analytics, we established an online data platform in Lake Region Economic Bloc, we realized that the people who are getting reinfected or having breakthrough infections were were health workers. Then we asked ourselves, why? Then we realized, one, they were vaccinated earlier, around March, when the vaccines came in 2021. 2, the nature of their work, they're in very close proximity with the infected. So our policy brief said, let us prioritize booster shots for health workers. That the media captured widely, and it happened. So there, yes, they listened. I don't know whether they listened because of crisis, but in that case, they listened. In all the others, it's a gray area. Thank you.
Professor Shem there, thank you very much. Professor Shem is a professor of statistics at the Great Lakes University of Kenya. Thank you. Let me just, I think we have about 15 minutes or so. I know the broadcast is really time sensitive. But let me just take a whole run through the second phase. We're going to be making some commitments, political commitments, and I think that's one of the objectives of this high-level dialogue on strengthening our pandemic preparedness. But during the pandemic, like Professor said, there's some essentials here. Our medical workforce, our access to DVTs, our access to vaccines in such a space like COVID-19, and indeed the medical oxygen and our health facilities. Let me go back to Dr. Sultani here. Where are we as Kenya in terms of strategic investment into those critical aspects? One, human manufacturing initiative. Are we making any progress on that front? But also, three, how do our health workers, health hospitals or health centers looking like right now? Have we increased on them? Do we have more intensive care units, high dependency units? Let's start there, because we'd love you to paint a picture for us on how Kenya stands right now and what progress has been made. Dr. Sultan, karibu.
Okay, thank you very much for those very pertinent questions. First of all, I'd like to tell you that within the strategy that we have established, which now is guiding implementation of health services, we have prioritized 4 main areas. And actually what you have talked about, there is a priority on human resources for health at all levels, starting from the community level to the highest level possible. And just to begin with, we have taken on more than 100,000 community health promoters to be able to go into the community and pick out public health issues before, they can get out of hand. And even when we now relate it to what we are talking about, this is going to boost the early warning system that we want to establish, even as we anticipate that we are going to see many more public health issues coming up, many more public health emergencies, whether they are outbreaks, epidemics, and so on. But also, a few months ago, we conducted a nationwide assessment, and we covered all the 15,000 health facilities in the country. And we were able to establish
Dr. Sultani, could you just hold the mic closer? Because we're trying to get the audio for your broadcast.
Oh, sorry, I have a very big voice, so I'm trying to... Yeah, so that assessment has shown us a whole plethora of issues that need to be addressed in the public health system. It's an extraordinary report. Because we are saying that we want to have an evidence-based approach to addressing these issues. So we have been able to even identify the human resource gaps that are currently existing. And we are looking at very quick ways in which we can be able to address these gaps. There are many interventions that we are looking at, but I'm happy that we are here with our colleagues, even from the union, the Secretary General and other colleagues I see in the room. And we are having discussions about how do we go about this. I'll just give 2 examples of some of the ways in which the strategies we are trying to put in place. We are looking at how we can start plugging the gap by quickly bringing in a certain number of health workers, approximately 20,000, within the short term, just to start bridging the gap. But we are looking at how do we manage to do this with the limited resources that we have. So we are discussing, and as I said, public health is about all the stakeholders. So we really have to ensure that everybody is playing their part, and that's why we are engaging everybody. And I can assure you we are having good discussions around that. Number two, we are also looking at, we are also looking at, in terms of health workforce, we are actually looking at how we can be able to now, we have already increased the total number of health workers who are available. Because a few years ago, we had, the pool of health workers that are available were not adequate. But now, after increasing the number of training institutions, accreditation, the problem that we are facing now is how do we absorb these health workers? So it's part of the issues that we are looking at. Now, with regard to health products and technologies, that is another pillar that we are looking at in our rollout for the universal health coverage. And you will remember that during the launch of the UHC, one of the days before the launch, which was led even by the president himself, there was a whole 2 days that were set for local manufacturing for health products and technologies. Not just the medicines, but all the other health products and technologies, name them, oxygen, diagnostics, everything. With regard to vaccines, we are actually working towards establishing a local vaccine production institution. And even currently, as we speak, the Kenya BioVax is really engaging. We have received a lot of support in terms of financial support, and we are making good progress towards ensuring that we will start having production. The Pharmacy and Poisons Board and the government in general, all sectors that are involved are working very hard towards attainment of the maturity level 3 status for the country, so that the vaccines that we produce and the medical products that we produce can actually be used in the region, because we must attain that level, and it is a concerted effort that we are making. And then finally, because I know we cannot talk about all those issues, we have actually mainstreamed all these plans in a legal framework. We are not just talking about things out there. We have actually passed 4 pieces of legislation to specifically guide the implementation of these pillars that we are talking about human resources for health, about moving our focus so that we start looking at health promotion and disease prevention, to limit the numbers of people who are coming to the hospitals, so that for every shilling we spend, and this has, I think our academicians have told us, that for every shilling we spend in health promotion and disease prevention, we save 9 that we would have spent in treatment, rehabilitation, and palliation. So we are also looking at the long-term reinvestment, divestment of these 9 shillings into strengthening these other capacities. It is a whole ecosystem that we believe with the time we are going to make it. But then, just the last 2 seconds, we have also engaged our unions, and we have requested that these things we want to do are very heavy shifts. We are lifting very heavy pieces. And we cannot achieve this if we are in an environment of turmoil. You called it violence and, that kind of environment. So we have negotiated a period. Somebody talked of 200 and I don't know how many strikes within a year. Yeah, we have negotiated a period where we can work together and achieve these issues, the grievances that we are hearing from our health workers. We try to see how we can address them as well as possible. And then after that period, we can review and see if it is, possible for us to move seamlessly without having disruption of health services. I think in the interest of time, let me pause at that point. Thank you.
Interesting things that are happening in Kenya. You've just heard it from the Director General that they're going to be recruiting about 20,000 medical workers. Is that good news to you, Doc?
When political leaders give, promises and also give plans, sometimes even when For example, on 20th of October, at the launch of the universal healthcare, to the minds of many Kenyans, it was that you go to the hospital and you'll access the care. But the story and the tellings in political discourse is very different practically on the ground as it comes to be. And that's why even when you are sitting down with government on 19th and talking about giving them time to actually implement these things with an industrial harmony, we were very categorical that strikes are cornerstones of industrial harmony. That is, if we have time for accountability and things to be implemented, and strikes happen in the process, that's actually to just tell them, follow this route. That's the reality. But when you get to the core of this issue, the 20,000 health workforce was promised in the manifesto of the current government when they were campaigning in 2 years before the election of last year. And it was very clear that they will employ 20,000 health workers within 100 days of them being in government. Today, we are at 400 days, and it's still a promise that keep on being put up. Even in the budget of 2023-2024, there is no any clause that indicates that there's going to be employment. And that's why we say that sometimes we have hope, but then it has to get into direction of implementation. And this is coming very strongly because the health workforce in many of African countries, Kenya included, are seeing more of a recurrent expenditure. They're not seeing the issues of health as an investment. And therefore, many times, and what categorically seeing in the counties from the director, from the controller of budget, when he indicates that all the 47 counties have exceeded their limit for paying wages and salaries. Most of them are at 50%. So there's actually no hope that they're going to employ. And if you look at the data that we have across the country in the last 5 years, before 2016, and I would say before this new constitution, the constitution came with very good things, but also with different things. There was almost annual employment of doctors, there was employment of nurses, but if you look at the last 5 years, out of, for example, just doctors alone, 5,600 who have graduated, only 1,000 have been employed. In the last 1 year of this government, out of 1,300 who have graduated, that's to be specific with doctors, only 37 have been employed. So you see, when we talk about the future, how is the situation now? If, for example, we get a situation of a COVID-19 again today hitting the country, what will be the situation in the hospitals? Were those measures that were put in place, have they been part and parcel of the hospitals for a sustainable situation, or they were just a reactionary aspect? Because one thing that is also very strong is the government have an habit of making policies, but then reacting to events so that these things can be handled at that time. But do they put measures that will ensure that if we have, for example, an outbreak of COVID now, things will change? That is non-existence. And that's the situation that we have. We know very well that the government has tried to bring up the aspect of community health promoters. And this, in essence, we know is really helping in mobilizing, mopping, and sensitizing the community on the need for care, that they need to go to level 2 facilities, they need to go level 3 facilities. But what is in those facilities? Do they have a planned budget to have the drugs in those hospitals? Do they have a health workforce in those facilities? Those are non-existent. My colleague has talked about very nice bills that have come up. They've talked about very nice bills that were signed on 19th. And we have had agitations, not only in Kenya, but across all Africa. What are we saying about these particular bills, particularly the Social Health Insurance Act? When you read in depth and details to the line and dots of that particular document, you realize that it's more of in the privatization of the social health insurance in the country. And why am I saying this so confidently? Because we have in current National Hospital Insurance Fund 6 million families across the country who have a comprehensive cover. And what does that mean? It means that if I go to a public hospital today and I'm not able to get care, I go to the next facility in that particular locality, whether it is private or public or faith-based. If if as a civil servant or as one of these people who have this scheme, you are able to get care in the country, you don't worry because the government is with you. You go get the care abroad. But with this Social Health Insurance Act, it will mean that if you go to the hospital, you can't get care, you must fundraise to pay this bill. It will mean that if you can't get care in the country, you must fundraise and go abroad. That is the Social Health Insurance Act. Again, this act has been put to purely be managed by private insurance companies. So we are seeing that you collect the funds from the Kenyans, and at the same time, 20% of it goes to the insurance companies, whereby they've not brought about what was the gaps in the management in the NHIF that was in existence. We are also seeing a very serious situation with this, the Social Health Insurance Act, because then it talks about a primary health care fund, and it talks about the chronic health, critical illness emergency fund, which is very important. These are taxpayers' funds. But then it brings something called mean testing instrument, whereby if you are in formal sector, you are not employed, they demand that you pay your premium annually. And if you don't pay, you can't access any of the government services, whether public or private. You can't access emergency care in a private hospital or public hospital. So in an essence, you're looking at it, are these things meant to help in access, or does it meant to help prevent? Does it meant to help the Kenyans access care, or in its essence, it actually impedes? And one thing we have been saying all along, and which is very critical in prevention, that to create a prevention, we must build ground up. And how do we do this? We need to have level 1, 2, 3 hospitals in the counties actually funded with enough health workforce, with enough commodities, to allow screenings, to allow early detections. And this is not only in Kenya. This also should happen the way it's happening in Rwanda, the way it's happening in South Africa, the way it's happening in countries in West Africa. Because with that, then we are certain that things will, the different outbreaks will be detected early. There will be earlier interventions, and there will be change to that. But if we keep on having the rhetorics and promises, then we may be here 10 years down and still speak about the promises.
Thank you. Thank you very much. I've been warned that I have about 3, 4, 5, 6, 7, 8 minutes. I'll use those, Mwangi. At least you have a national insurance. We don't in Uganda. Dr. Chabainze.
I think it would be very important for us to just say that these acts have just been signed. And now we are going through the process of doing the regulations, to operationalize the acts. Mm-hmm. When they are in this form, they can be interpreted in very many different ways. So what I would just request is that let us allow the process of developing the regulations and implementation to come, which is an all-inclusive process. Actually, most of the issues that are being talked about by my colleague are the ones that are supposed to be addressed. Even this social health insurance is actually supposed to now do away with the payment of, from pocket payment as a health insurance. It's a major cornerstone of this bill. So I think we need time to allow the process to be completed so that now we can be able to review it.
All right.
It would be good for us to just put that out there so that we don't now create a picture of this very bad situation, because we can really interpret this thing in very many different ways.
Dr. Sultani, thank you very much. You had to do a comeback. I expected that, but thanks a lot for that clarification. Let me bring in Dr. Daniel. At least the Kenyans have the national health insurance. We don't. And that is very central in managing pandemics, access to medical care. We know that the out-of-pocket during the pandemic was exorbitantly high. People took their relatives and their loved ones in private health facilities. The government facilities were highly congested and full. We certainly, as a country, if we're going to face the next pandemic, have to have a national health insurance scheme that is going to support us through the pandemic. Where are we at as a country?
Thank you. Uganda has been on the journey of developing a national health insurance scheme bill for now almost 7 years. Almost 7 years. And the journey is challenging because leaders have what we call context. And they do context analysis. You don't want to put out a bill to help everybody, and everybody feels that the bill is to help the government. the lenses through which leadership sees things is because they have a panorama view, they know what they have been funding, and they know what the bill will contribute. So I'm happy to say that the bill is now back on the floor of Parliament to be assented to, back to be signed by Cabinet. So that's where we are as Uganda. And I'm privileged to have seen the back and forth. And if we're to discuss why it takes a few issues, it's because you have to listen. The manufacturers are saying, are you putting another tax? Because you are requiring my health worker, my employees to contribute. The bill is one part. There is some good news which has come out of the recent pandemic observation. And that's what I say, leaders have a chance to listen, that when we come up with policies, like my brother has been saying, when our leaders promise to take up people in the health system, they also have to know what is the resource envelope they're going to pick from. Government of Uganda doubled, and you need to tell everybody, doubled the salaries of health workers. Doubled. Interesting, clap for it. Because when you make such a bold statement, all the people who do HR planning will say, that's not possible. And it has tilted the balance. Now, it is more profitable to work for government than to go and run around. It is now more attractive to remain working in Uganda than coming and working across or taking a flight elsewhere. Because now you know that you are earning good money, but within the comfort of your country. That there are other social amenities which come from working near home. Those things are hardly talked about. But now you see, we are able to attract and retain all the people who have been maintaining the other Western world sciences. When you go in those labs, I mean, I've been there. When you go to those hospitals, you look at the profile of the highly talented health workers or researchers. They're Africans. They're Africans, but because resources have kept them there, we need to find a way to reverse brain drain. And that's how we shall build all these things and get ready. But I also wanted to say that infrastructure has developed. After pandemic, we see ICU beds, oxygen plants, we see emergency operation centers. We've done joint evaluations to see where we went wrong and where to learn from. We have also seen cross-border collaborations. When there was Marburg outbreak in Tanzania, we saw how Uganda joined the team. We know how we got exchanges from South Sudan. We know how we are having the East African network. We see how we are talking as Africa at the pandemic treaty, where we meet and say what is African's position. So all these help us galvanize, and the Africa CDC now is becoming a common voice for us, and I think we shall have to leverage on that.
Dr. Chabanze, thank you. Professor Shem, you have the final say at this. I can see Mwangi is coming closer. All this requires a deliberate effort to finance our healthcare system. Do you see that happening in Kenya and in Africa? I mean, we ratified to the Abuja Declaration, and all that remains a document about at least allocating 15% of our budgets to the health sector. We will be ratifying to all these documents, but at the center of this is the funding of the health sector. I would love to hear from you. Do you see that from your lens, that governments, African governments, are taking the healthcare system very seriously, or we are now directing money into politics, increasing salaries of members of parliament, and giving all the beneficiaries to the benefits to our presidents and to our executive? Is there a direct effort to fund the health sector in Africa, or at least in Kenya?
Thank you very much. I must first say that there is some level of improvement, especially after the pandemic. Then I will continue to add that that is one of the major threats we have to the pandemic accord. Commitment, national commitment, local commitment, domestic commitment versus international or global solidarity. Look at it this way. This is my country. I am a researcher. And I know we don't own our sciences. We don't fund our research. For example, KEMRI. Most of the research being done there, are as a result of thought processes that have happened elsewhere. No, we are just spanner boys. They are trying to do something. Because we do not fund our own sciences. That must change, and we must have a candid discussion on that. The next threat, other than finance, is nationalist versus global solidarity. For example, look, when Omicron came, we should have thanked the South African scientists for having successfully sequenced and discovered this. Look at the international community, what they did. They decided to give, first, one is to limit to blacklisters. All South African countries and even Africa, they started blacklisting us. Then this was even more worse now that the Africans themselves started putting ban on travel in their own member states, which was even terrible. So there's the national protection against global solidarity. Now, let us go ahead and point fingers at the international community. When we needed vaccines, first, they hoarded the vaccines. That is a very beautiful brand of global solidarity, I think so. Two, they gave us vaccines with short shelf lives. Within no time, it has expired. Now that is global solidarity. Then, if you look at the ratification of all international accords, the big brother is always lackadaisical in trying to ratify. For example, ICC, have the big brothers ratified it? We do not want this pandemic treaty to be like the ICC thing, where people choose now, we are the big brother, we are not going to ratify this. Now, the other one is solidarity, is the sovereignty, sorry. You realize that during the pandemic, there are countries that kept their data. One of them, I'm sorry, was China. Up to the time that there were 23,000 scientific publications, China was still censoring universities and academics and researchers from publishing anything on COVID. It had to go through the ministry, then it has to go through the academic institution for it to be approved. Now, there are many other countries that do not want to share their data because they think there's some kind of espionage involved in data sharing. So we must try to limit all that. Thank you.
Thank you. Thank you very much, Professor Shem Otoe, Professor of Statistics at the Great Lakes University of Kenya. A very big thank you to Dr. Sultan Matenjecho, who is the Deputy Director General of the Ministry of Health, Government of Kenya. Thank you, Dr. Daniel Chabainze, who is the Director of Public Health at the Ministry of Health, Uganda, and indeed Dr. Davji Atela, who is the Secretary General at the Kenya Medical and Dental Practitioners, Kenya Medical Practitioners and Dental Board. Thank you very much. Dentist Board, thank you very much. Union, oh, okay, great. The Kenya Medical Practitioners and Dentist Union, great. A round of applause to my panelists, ladies and gentlemen. Thank you very, very much. Sorry I didn't give you an opportunity to react. Our time is fast spent, but yeah, I think Kenneth Mwangi is telling us that there's going to be that opportunity. But let me just invite you, Kenneth. Thank you very much, Mr. Mwangi, Dan, for giving me this opportunity. You're watching NTV, and I hope you enjoyed the discussion. Over to you.
Thank you very much. And just briefly before we release the gentlemen, we will allow for 1 or 2 questions. If you have any questions that you'd like to throw at them before we close this part of the engagement, there's a hand there, there's another one here. So we'll just request that we take 1 round. We'll pick the questions in one, then we'll have them responded to, then we can close. So if I could just have 1 microphone. Thank you. So I see some hands at the back there. So I request that you just introduce yourself, the organization you represent, and let's kindly make our questions brief so that we can be efficient with time. So you could just stand up kindly.
Yes, good morning, colleagues. My name is Agri Aluso. I work with Pandemic Action Network as the Director for Africa Region. And I want to thank the distinguished panelists. I think this has been a very engaging discussion, very pertinent, important issues in our quest to really attain health sovereignty. I think it's been articulated very, very succinctly by Professor, how we've always been extending our begging bowls to the outside world on very critical health security issues, which is not something that we need to continue doing. So my question is to the government representatives in the panel, Dr. Daniel, Dr. Matendechere. I think you've had very eloquently the issues that have been tabled, and I'm sure you've been in this journey for the longest, more than many of us. So there are many processes currently afoot within Africa and globally. I would just want to know from you, I think the biggest challenge that we faced in issues of pandemic preparedness and response are the issues of equity. Equity in accessing the essential medical countermeasures, and I think they've been enumerated, the reliance on externally produced and centrally procured countermeasures. I think it's been shown that we can't rely on that in times of emergency. We saw what happened in India when they had to stop the export of AstraZeneca, which was our only vaccine at that time. And that means we have to make all efforts to have our production here, have the countermeasures produced in the regions where outbreaks are likely to occur. And we've seen a surge in outbreaks within the Africa region. So my question is, we have a lot of commitments. The Partnership for Africa Vaccine Manufacturing, we have the new public health order, which has been really politically propped by the Africa Union and being driven by Africa CDC. What are our governments doing to ensure that these initiatives see the light of the day? We've seen a lot of other pronouncements before. The Abuja declarations, the Maputos, the commitment to assign at least 1% of our GDP to R&D, which has not been attained. We are currently at 0.5. What are we going to see happening differently after experiencing the iniquities during COVID? Thank you.
Thank you very much. And we'll have a second question. I think we had a lady here. This has many questions. So I request her to keep it very brief so we can accommodate as many people as possible.
Great. My name is Julia Kosgei from the People's Vaccine Alliance, Policy and Advocacy Advisor. My question is to Dr. Sultani. You've talked about Kenya participating in these international processes that Agri has just mentioned. And commendably, Kenya has done very well in through the Africa group, through the group of equity to, try and embed language on equity within the current text that we have. My question is, the president enacted this interministerial committee to support the government in, developing proposals that can be forwarded to the negotiating body. But from where I stand, the civil society, the union, for example, has not been invited to participate in contributing to Kenya's proposals to this body. How do we engage? How do we participate in this process? That's question number one. The second question is, you've mentioned that Kenya is financing production. We have our own state-owned manufacturing, biovax manufacturing plant now that is being set up. What conditions have been included in this funding to ensure that access is guaranteed for the end product? Is it starting from R&D? Is it from the production end of it? How do we ensure that Wanjiko, as we say in Kenya, can access the products that come from these state-owned facilities?
Thank you very much. And in the interest of time, I'll just take one more question from this table. And you will kindly pardon me from this table so that we can... Then I believe the panelists should still be around and we could engage them on the same when we take a break.
All right. This is Wanangwa Mhango, Outreach Scout Foundation, Malawi. My question goes to the government. There's been a mention from the statistician that during this pandemic period, some big fish got even richer from the pandemic instead of helping address needs that were taking place in the community. What are the initiatives that have been put in place to ensure efficiency as well as reduce issues of corruption that were occurring? At the same time, we're talking, we can properly prepare for the pandemic if we are as well including the grassroots and we're moving upwards. That includes empowerment of health workers as well as other people, where health workers are doing the work because they are empowered, not because they are going to get something from it. What are the initiatives we put in place to empower the whole community so that we can join and participate in the preparedness and response? Thank you.
All right, thank you very much. And I think I will just close it there kindly, in the interest of time. And I will request that the panelists, I see there was some, the government is, as usual, on the spot, so I will hand this.
Thanks, Mwangi. Profiting from the pandemic, Dr. Sultani, do you want to start there? Some questions were really posed to you. The commitments of Kenya towards the PAVAM. You could take up the questions that have been asked. Please,
so maybe because of time, I'll just say that generally the government of the Republic of Kenya is fully committed to the processes that are ongoing with regard to trying to craft the new global architecture around global health. Personally here, I sit in the working group for International Health Regulations Amendment as the vice chair, the global group. That's why I even met Daniel. And I represent Africa in the Bureau because it's a global process. There are two processes. One is to amend the IHR. The other is to come up with a pandemic accord. The committee that Julia talked about is an intersectoral committee where we prepare our submissions to those two processes. Now, as vice chair of the WGIHR, we have worked with countries, African countries, all of them, and we formed an African group where we meet regularly. We have galvanized support from Africa CDC and other continental bodies. And for the first time, Africa is presenting its problems in one voice because we realized that the issues that we are facing here in Kenya are exactly the same issues that are being faced by other countries in Africa. So we said, let us present as Africa group in one voice. And we have been able to now tackle the issues that Aluso brought up around equity. We are putting in very good text, textual suggestions, which are coming from these processes that we are doing in country through the interministerial team. This interministerial team was just approved by cabinet a few weeks ago. And our intention is to be able to make sure that we bring in the voices of all stakeholders before the end of this process, because we expect to provide feedback to the World Health Assembly in May next year. Now, just to talk about the corruption, so to speak, that characterized the COVID response, maybe some of the issues that have been done, very big changes have been undertaken, consequential changes in the institutions that were implicated in the corrupt practices. Number two, the government, another pillar that I did not talk about in the UHC rollout is digitization. So we are digitizing all our financial processes, and as you know, when we digitize, we cut out a lot of windows of opportunity for corruption. And then, of course, we have also tightened in the sections of the law where we can be able to stem some of these practices. That has also been done. Thank you, and back to you.
Real quick, civil society, you've not brought them on the table. You want to answer that?
No, of course, it was in line with the negotiations that are ongoing around the global health architecture, and that is something that we fully intend to do, because I am also part of that interministerial negotiating body, and we are looking out to collect views. We incorporate as many stakeholders as possible, and where possible, we are going to bring in the civil society as well.
Okay, thanks. Dr. Daniel?
I wanted to mention about vaccine, because there is no usefulness of trying to manufacture a vaccine if we have not prepared the community to accept vaccines. We have in Uganda 13 preventable vaccine antigens we are giving. So let's prepare to make sure that our vaccination rate and acceptance are so high so that when there is something that requires a vaccine as an intervention, we are entering into an accepted and prepared community. The media has a lot to do with getting the community ready to receive whatever intervention.
All right, thank you. Dr. Davji.
I'll just say that, you know, as Aluso has said and many others who are putting up their points, that there are very many protocols and declarations and even conventions that have been put up across the world. And I will tell you that even the OECD policies that were recently talked about, African countries are very quick to sign them, and they're very quick to commit, probably to show some acceptance from those particular regions. But then we have leaders who sit in a complacency tables. They do not get down to actual implementations of these particular policies and all these regulations and even the conventions. That's why I believe these conversations, such as that that organized by open societies and nation media, are very important because they bring one thing. Because you can give promises, you can give plans, but then for healthcare, you can never lie. If healthcare is dysfunctional in any state, we will see actually people dying. We will see people suffering. We will see people contributing to get the funds. So when we talk about the preparedness, we must run with it. We must also put part of our investment. Our money must go to it as a country, as a continent, to see that we actually mean what we are saying and the commitments that we are putting in those countries. Thank you.
I wanted to say one thing. In Uganda during COVID, the population raised over 350 double cabin cars from their resources, which they donated to government to improve equity and access to countermeasures of COVID. And the people contributed the money to the government.
All right, Dan, thank you. Shem, you have the final say at this. Do you want to make any reaction, Professor?
I think that all our governments in Africa must look for ways of stopping being the weakest chain in the link. That comes with commitment. Most of the time, it is a lip service. We're saying, we are planning to do this. You can't plan forever. Uganda is planning for 7 years to have their version of NHIF. You see, we can't accept that. For example, if you are in crisis and you need urgent help, and I am responsible for your help, I don't have to tell you that, you see, I'm still planning to come. No, you must, at least we should see definitive steps towards achievement of that. Yes, legislation in Parliament. It looks like it had gone out of Parliament. It is now back. It will again go out. It will come back. No, we really want it to be there with all commitment. And we are also asking our parliamentarians who sit in various committees that the reason why they are there is not for allowances. They are there because we elected them to represent us and to burn the midnight oil to ensure that these legislations relevant for the enactment of Social Health Security Fund or the different laws that will be required, national laws to implement Pandemic Accord, are in place within the shortest time possible. Let us stop politicking, spending money in politics, flying from one area to another to plant trees, instead of sitting in Parliament to do something meaningful for the people.
All right.
Professor Shem, thank you very much. Dr. Sultani, Dr. Daniel, Dr. Davji, thank you very much. Over to you, Mwangi.
Thank you very much as well. And thank you for being part of this conversation. Like I said, it continues online. We shall still be streaming the conversations here. And you could share your views using the hashtag Nation Leadership Forum. So at this point, we close this broadcast. Thank you for joining us on NTV. But like I said, we shall still be available online. The conversations will still continue there. And after this, this, we're going to be taking a short break, but after this, we shall come back with a presentation on how to accelerate vaccination coverage in Africa and adoption of innovative technologies in strengthening health system performance. Then we shall have a panel discussion, which is on uptake, distribution and logistics, equity, challenges and opportunities to improve vaccine distribution in Africa for future pandemics, which shall be moderated by our very own Helen Aura from our Health and Science Desk. So we thank you for joining us on NTV for this broadcast. Like I said, after the short break, we'll be back online with the discussions that I have mentioned. Thank you for joining us. All right, thank you. We're closing for the TV part. So that's why I had to have an awkward silence. But thank you once again. So at this point, I'd like to thank the panelists as well. I could see some kind of nice jealousy across the border. When one says we've doubled our salaries for our healthcare, he was about to jump off his seat. But when he mentioned, we were talking about NHIF, SHIF, and the Ugandans are like, you guys have that. So there's a good exchange of learnings here, and we look forward to having more of that even as the program continues. So at this point, I'd just like to mention that the People's Vaccine Alliance has a virtual reality film that you can take time to go and see. They're stationed at the very back. You could just give some insights on some of the hubs that have been put in place in line with the same theme of what we're talking about. But at this point, I invite you all to have some tea. We'll take a tea break now. Then we'll come together again back here at, what's the time now? 11:12. It's 11:12. Let's meet here at 11:40. 11:40. So first you can go 40. All right? Karibuni sana. Thank you. Everyone to just settle in so that we can pick up the next part of the program, as we also get to experience climate change. Our climate is changing real time. We came in, it was raining, the sun has been shining, now it's going down again. So you're most welcome. All right. Just once again, in case there's anybody who is with us and you can hear me, I kindly request that we come into the room to allow us to proceed with the program. And I guess once the my director, Mike, once you're ready, let me know. Okay. All right. I would like to call the meeting to order. And at this point, as we continue with the discussions, I think the opening panel set a good tone, where we had some very interesting insights. For those who may even have been watching us on TV or online, just appreciating the dynamics of the health space and the vaccine and pandemic preparedness dynamics of different countries in the region or in the continent. We got to get a good feel of that in the panel discussion that was there before, from governments, that is both Kenya and Uganda, as well as from unions. For instance, we had our union, our Medics union represented here. And so we're looking forward to getting a lot more insight. At this point, we're going to get a presentation on how do we accelerate vaccination coverage in Africa and adoption of innovative technologies in strengthening health system performance. I'll just read that again. How do we accelerate vaccination coverage in Africa and adoption of innovative technologies and technologies in strengthening health system performance? And this is going to be presented to us by Coletta Kilu, who is Monitoring, Evaluation and Learning Lead at Amref Health Security Unit. So I invite her to the podium for now. Karibu. So as she comes, just remind you, she's going to be giving us a presentation on how should we accelerate vaccination coverage in Africa and adoption of innovative technologies in strengthening health system performance. Karibu.
So good morning. I think we still have a few minutes to afternoon. Good morning, everyone. Yeah, so I think you've heard my name. I'm Coletta Kilu from Amref Health Africa. I support the monitoring, evaluation, and learning at Amref Health Security Unit. And for today, I'm standing here on behalf of my colleague Jacqueline, who was to be with us here today to discuss this topic. But I will be representing her in the next few minutes. So looking at the topic, we are going to talk about accelerating the vaccination coverage. I know most of us might be wondering, like, it's been around, is it 2-3 years as we've been doing our vaccination programs? And so the question would be, why are we still talking about vaccination? Why are we still talking about the approaches for accelerating vaccination coverage? So we are going to look at few statistics in the coming slides just to mention that, to show where we are, especially when it comes to COVID-19 vaccination, and to show that we still need to put a lot of effort to ensure that we reach the target coverage that we've been guided. So for now, I'll wanted to start the next slide. Just to talk a little bit about AMREF, because AMREF, since the beginning of the pandemic, we've been at the core of vaccination. We've also been at the core of COVID-19 activities. And so I won't spend much time on this because I know we've interacted with the organization. But just to mention that we have around 150 health projects that are distributed across 35 countries in sub-Saharan Africa. And so most of these 35 countries, we've been able to also reach them in terms of public health emergencies, including the vaccination programs. So we also have a huge coverage in terms of staff, and just to mention that 94% of those come from Africa. Then we have the areas highlighted in red are areas there we have programmatic presence with no country office. We also have the areas highlighted in black where we have both programmatic presence and also country offices. And then the blue is where we have our fundraising offices. Besides that, we also have the subsidiaries where we have the AMREF Flying Doctors, the University, and also AMREF Health Innovations that are also based in Nairobi. Next slide. So while we are talking about health emergencies, and I know it has become of interest for many organizations and also partners, looking at our strategy, we have incorporated a strategic objective that is very specific to health emergencies. And when you look at this, we have around 10 strategic objectives, but the 9th one is what is of interest to us today. And from that, we have been able to unpack it in the next slide, where we have developed around 4 thematic areas that will guide our implementation of the health security interventions. So looking at the 4 thematic areas, and it's based on some of the interventions that we have been using, which is strengthening community health systems. Strengthening, as you've heard from the morning panel, we cannot belabor the importance of communities, especially when we are talking about pandemic preparedness and response. And so we have our interventions around strengthening the community health systems and also leveraging the existing structures that we have around the communities. The second one is around disease surveillance and intelligence, where we are very intentional about this. And for this, it's mostly about supporting the development of the policies and also guidelines around disease surveillance, but also continuous capacity building. The third one is on strengthening public health institutions, and then lastly, laboratory diagnosis, which of course plays a huge role when it comes to public health emergencies. So on the next slide, we will implement this, and even as we look at some of the interventions, we have cross-cutting enablers, which again also came out from the morning panel. And the first one is on health workforce. So health workforce comes in the center of everything that we do, and it's very important and very critical to ensure that as we design our interventions, then we have interventions specific to the health workforce, which we're going to look at it. And then research and learning, again, is a very huge component, because as you see with most pandemics, and especially COVID-19, we've seen the context changing, and it has also been evolving. So there is need for us to make deliberate efforts to ensure that we invest in research and learning around not only COVID-19, but also pandemic. So we're going to look at some of the innovative strategies around that. Besides that, we also use a 4-pronged approach for us to be able to implement our health emergencies, which is around health system strengthening. So we have the internal and external ones, and the first 2 are external, whereby we look at the health system strengthening approach. We also look at multi-sectoral collaboration and the One Health approach, which again has come up. And then internally, we also look at developing a one global framework for health emergencies, and then having country level ownership so that they're able to work with different local implementing partners to ensure that we implement all our health emergency programs. Then the last one is again also continuous learning and adaptation. So before we go to the next slide, which again is now, we're going to enter in the purpose of this session, I just want to pose a question. How many of us know, how many countries from the 55 member states that you have, how many countries have reached the 70% vaccination coverage? Just a try. 5? How many? We have 5 from here. Fully coverage, 70%. Countries, the number of countries, how many? 0. None. None has reached 70% in Africa out of the 55. Any other try? Rwanda? Okay. So we have around 14 countries that have vaccinated over 70% of the eligible population. And this is as at the latest report that was released by Africa CDC in early November. And besides that, looking at the vaccination coverage, now as a country, as a continent in Africa, where are we? What percentage are we? 51, yes. Any other try? 56? 50? 46? As a continent. Any other try? Great. So we are around 52% in terms of vaccination coverage around the globe. So in the next slide, I'm happy that this conversation is really happening because we still have a long way to go when it comes to accelerating the vaccination coverage. So you look at 14 countries out of 55, that translates to around 25%. So we still have a 75% to support, and in terms of ensuring that we reach the 70%. And also looking at the 52%, which is slightly above half of half, we still also have some work to do. So the question for us is, what exactly is it that we need to do to ensure that we accelerate the vaccination activities? And so every other week, we have Africa CDC that conducts weekly epidemic intelligence, and so from their reports, they are able to share with us what are some of the top emerging priorities. Because right now, we're not only talking about COVID-19, we've been having, even as we implement COVID-19 interventions, we've been having so many emerging public health threats that have been interrupting even the work that we do around COVID-19. So we have a list of around 100, but from those 100, then they're able to prioritize what are the top 10. And so for the report that was released last week, these are the top 10 health emergencies that were released, and you can see COVID-19 is still with us. We have anthrax, cholera, chikungunya, among others. So those are the ones, and it's always important to ensure that we keep in touch with this so that at least even as we design our interventions, then at least we are guided and we are able to prepare adequately. So with this, then, as I mentioned, we've been, in the next slide, we've been implementing a number of vaccination activities. And what are some of the challenges or the gaps that we have experienced over time? So as we started our vaccination activities, we experienced a very huge shortage of vaccines and also medical supplies. So again, as you mentioned, which I think was also discussed in the morning discussion, we had, of course, vaccines were supplied, and then within a very few minutes when people were fighting for the vaccines, then they disappeared. So again, that is one of the challenges that we experienced, but with time, I know with all the stakeholders that have come on board, then this has stabilized over time. Then again, we've also had, despite having COVID-19 as a pandemic, we've still also been having emerging health priorities and events in the continent. For example, we've had Ebola in Uganda, which also disrupted our COVID-19 interventions, but still we had to push the vaccination activities as we respond to Ebola. We also had cholera in Kenya and Malawi, and cyclofreding in some of the South African countries, that is in like Malawi and Mozambique. Then also with this, we see that with the change in context for COVID-19, we also see changing priorities. And this is mostly for the ministries of health so that they are able to respond to other emerging needs and other competing interests within the different countries. For example, you remember that services were disrupted when COVID-19 came because people were not able to access the health facilities. So when things isn't along the way, then the health facilities were rushing to ensure that they vaccinate the children who had missed their routine immunization. So this got us thinking in terms of how do we still continue with our COVID-19 vaccination programs as we still take care of these other emerging priorities by the ministries of health. Then the other one again is vaccine hesitancy. This I know has been a huge challenge when it comes to vaccine administration, and so it has even gotten worse, especially with the change in dynamics and also the reduced cases for COVID-19, and even after the de-escalation of COVID-19 by WHO. So with these challenges and many others, then we have managed to implement a number of interventions, which is what is summarized in this particular slide when it comes to accelerating COVID-19. So the question has always been, what is it that we need to do for us to ensure that we still keep up with other emerging priorities, but still continue with the vaccination activities? And so one of the things that we have come to realize is that health workforce, building the capacity of the health workers is very critical. And I know this happened when COVID-19 came, where they were all trained on COVID-19 and all that, but we realized also with the changing context for COVID-19, there's need to constantly build their capacities on the changing context, including the vaccine administration and also how to reach the vulnerable population. There's also now the upcoming issue on integration of COVID-19 vaccination, and this has made we've had most of the governments now developing integration plans to ensure that they incorporate COVID-19 vaccination within other primary healthcare services, but also with routine immunization. So with this, again, we've been having requests in terms of, or gaps, in terms of how should this be done. When it comes to somebody has to come for their NCD screening and has to get their COVID-19 vaccination, how should that then be done? So there's need to develop guidelines and policies around that to support also the health workforce. The other thing that we realized also as we implement this is that besides capacity building of health workforce, there is need to ensure that we are also motivated, that they are also, we take care of their environment. With time, and also if you can also flash back, you realize that people had to, were coming for the vaccines, but with time, because of the hesitancy, we had to take the vaccines to the people. That is in the last mile population, and this had to, we had to redesign our interventions in terms of incorporating outreaches and also door-to-door vaccination. So when this happens, then, and we all remember we also have a target of 70% vaccination coverage. So health workers were again experienced with so many challenges along the way. Part of it is issues to do with insecurities, issues to do with also the harsh weather conditions. So how do we ensure that we incorporate or will take care of the environment in which they work with? So there's a whole element in terms of health worker motivation, besides just building their capacity. Then there's also the element of community engagement and risk communication, which played a huge role. Remember, we said that communities are at the center of everything that we do. And so for this, there is need to ensure that we at least build their trust. We get their trust because there is a lot of, part of the vaccine hesitancy was mostly because of the myths that were existing about the vaccine. So there is a lot of work that has to go in terms of community engagement, in terms of creating awareness, in terms of also building their capacity, and also for them to be able to know what role that they play when it comes to vaccination activities. Integration, I have talked about that, and just to add on that is that for integration to happen, we realize that there is the planned integration, but there's also the opportunistic integration. So for integration, at that particular time, when you started in vaccination activities, you realize that it was just at the facility level. So for integration, again, you also have to be on the lookout, especially for the opportunistic one. In Kenya, for example, we have integrated our COVID-19 vaccination with the drought response initiatives in Marsabit when we had the drought response activities happening, and we've also integrated this with other activities just such as the HPV vaccination in schools, and also now routine immunization and these other primary health facility services at the facility level. Accessibility of vaccine sites is one thing that, again, right now we need to ensure, because we realize that there is a community, the last mile population, that has been forgotten, especially when it comes to vaccine access. So for us is also, as we do incorporate the outreaches and also the door-to-door, is as AMREF, we use the mobile vaccination clinic, which was able to provide now the vaccines to far-off facilities, but also to the communities in the last mile population. Data management, monitoring, and learning. I think it has been overemphasized here that we've had huge challenges, especially when it came to access to data from the different countries. And this is something that I know led by Africa CDC, they have been working on developing data sharing agreements with the different member states so that they can ease the access and the protection of data, especially when it comes to public health emergencies. So I know there's a little bit of work that is going around that, but then again, they still need to do a lot when it comes to strengthening the health information systems and interoperability of those systems. So the experience that we've had is that different countries use different technologies, especially when it came to follow-up of patients and even collecting that data. So we had countries that were using the COVID-19, the manual registration process, but others were way ahead when it came to now the registration process, where they had digitized all the data collection tools. So we need to also identify some of these gaps and ensure that we develop interventions that are specific to strengthening and ensuring the interoperability of these management systems. The other one is on global collaboration and support, just to ensure that we continue to support continuous vaccine supply and also distribution, as well as supply chain optimization, just to ensure that we track the vaccines. We are also able to provide even predictive analysis as to when these stocks are expiring, but also how long they are able to take the different governments, or to serve the different demands that we have. Public-private partnerships, I know we have talked about the role that local implementing partners play, especially when it comes to health emergencies. So as we look at partnerships, there's also a need to ensure that we provide deliberate activities to build the capacities of the local implementing partners when it comes, because they are connected to the communities on the ground, and they are also the first people, very critical when it comes to surveillance and also communicating disease outbreaks, as well as designing the interventions. Then there's also the international cooperation for technology transfer, which again was talked about in the morning. When we started also our vaccination activities, I think less than 1% of the vaccines came from Africa, but I know, again, we've also had a lot of interventions with time, and this is what has eased the challenge that we had, especially because we did a lot of demand creation, but when it came to supply, then there was a gap. So this has improved, but again, there is need to also continue supporting that, and the policy advocacy around around also capacity building, and also the vaccine development, and also distribution. So with that, we're going to look at some of the technologies, because to implement that, of course, again, technology, we have to be innovative in everything that we do. And we've talked about integrated digital health solutions, whereby if the interoperability of the systems, but also implementing digital platforms that are able to track even patients, because especially the challenge that we experience and the stories that we got from the ground, especially for people who are using the manual registers, is that when you're coming for your second dose, then you had to like go back number of pages for them to be able to access your details and to record that. So there is need to ensure that at least we implement digital platforms, especially when it comes to health emergencies and reporting, real-time reporting on such and updates as well. Telemedicine also and remote monitoring. We cannot overemphasize the importance of that, as we saw the experience when it came to COVID-19 and all boundaries were blocked, and also there was little movement when it came to that. So telemedicine is one of the innovations that we need to really invest in, especially when it comes to health emergencies. Supply chain innovation, again, just to ensure that we enhance our transparency and efficiency when it comes to vaccine supply. The other one is on health information systems, which we have talked. It's a high time that we go digital, and especially when it comes to data analytics, when it comes to the health informations and health records at the facility level, especially just to ensure that we have or we provide comprehensive patient management at all levels. Then the last one is also on e-learning. When it comes to capacity building and also training. So as AMREF, we have also utilized a number of e-learning platforms when it comes to building the capacity of healthcare workers and also the community members. We have used a platform called Jibu for the community, for the facility-based healthcare workers, and also LEAP for the community based healthcare workers, just to ensure that we constantly update them or train them on especially on COVID-19, and also when the context was evolving. Then again, the last one, if the last slide is just to summarize. If we forget everything else, we just have 3 points that I'd want us to take home. Next slide, please. Yes. What is it? The question is, what is it that we need for us to have, what will it take to have what we need? Because we've looked at some of the challenges that we have experienced, and we see that some of the interventions that we have been implementing over time. But again, one of the things that we can emphasize is that the need for strong public health institutions. And we have seen the role that Africa CDC has been playing over time in terms of being able to conduct those analyses and also to prioritize what are some of these public health threats. So it enables the governments, it enables also organizations to be able to plan adequately and prioritize our resources, because we know that our resources are very, they are scanty. So how can we be able to efficiently put them in use? It is through proper planning, and there is need to ensure that we strengthen and we provide technical support to the public health institutions at country level, and also supporting also Africa CDC to ensure that they implement their mandate. Then the second one is also strengthening community engagement. As you've seen, the role that communities play in this, we cannot belabor that. They are at the center of everything that you do when it comes to health emergencies, and so there is need to constantly build their capacity, constantly build their trust for us to be able to improve the vaccine uptake at the community level. And then also now the innovative strategies. When it comes to vaccination, we've seen that most of these health threats or health emergencies, I'll take an example of like Ebola. Ebola used uses the ring, is it the ring strategy, to be able to reach their vaccination, to implement their vaccination activities. And this is for everybody who's come in contact with anybody with an Ebola case, then should be vaccinated. For COVID-19, we used the priority was given to, of course, the vulnerable group, and also the high priority group, including the health workforce, people with comorbidities and such. So there is need to ensure that we come up with innovative strategies, and especially now that COVID-19 is no longer a public health threat, so, and we still need to reach the 70%. So the question is, what is it that we need to do? How innovative can we be to ensure that we implement or we reach our recommended vaccination coverage? So I think that's it from me. Yeah, thank you so much, and I welcome any comments and questions.
Thank you very much, and we shall allow you to sit. We can pick questions alongside the panelists that will be coming up next. And speaking of which, now we are going to be heading to our next panel discussion. And this discussion is titled Uptake, Distribution and Logistics, Equity Challenges and Opportunities to Improve Vaccine Distribution in Africa for Future Pandemics. And it's going to be moderated by our health and science reporter, Helen Aura, who will be now coming on stage and who will then invite her panelists as we go through this session. Then after which, at the tail end of which, we shall have a quick Q&A on the same. So Helen, karibu.
Thank you so much, Dan. Ladies and gentlemen, good afternoon. My name is Helen Aura. I do trust you have had a splendid morning, and we'll keep engaging and leaning in and gleaning into the conversation that will take place. Our morning conversation, we learned much more about how COVID-19 disrupted health systems in a lot of African countries, and that exposed many African countries in the level of preparedness. The next session, I'm going to be joined by a panel of ladies in the research and a gentleman as well. And we're going to delve more on the role of researchers in the industry. On stage, I'm joined by Ms. Sakile Kaweka. Ms. Sakile, kindly come on stage. Ms. Sakile is a policy and advocacy project manager at the South Africa Health Technology Advocacy Coalition, whose secretariat is hosted by the ARM Institute. Welcome on stage, Mrs. Sakile. Ms. Sakile, you can have a seat. Thank you. My next panelist is Dr. Adrian Kivumbi. Dr. Adrian is a pharmacist and a pharmaceutical consultant with a diverse and rich background in the pharmaceutical industry, and he boasts of a comprehensive background in the pharma sector with significant roles in the pharmaceutical companies, such as Director of Operations in Kisiake Industries Limited. Welcome on stage, Dr. Adrian. A round of applause for Dr. Adrian as he makes his way on stage. Thank you. All right. My next panelist is Maureen. My next panelist is Maureen Owor-Okoth. Maureen manages the Advocacy Coalition for Health, Research and Development, CREED, that is hosted by AMREF Africa in Kenya. Welcome on stage, Maureen. Thank you so much, ladies and gentlemen, for making time to be with us here on this great day and great platform. I'm joined by beautiful ladies and a gentleman. You can clearly see beauty and brains on stage with me today. And as we delve into the conversation today, we talk about the role of vaccines. And when we talk about COVID vaccine and how COVID hit a lot of African countries, let alone even African countries, but the world as a whole, you're all in the research field. You're all in the pharma sector. That's one area where we rarely highlight what actually happens in that particular area. And I just want to break the ice, and maybe you can tell us, what is the role of research and development when it comes to pandemic preparedness? We can start with you, Sakile.
Thanks, Helen. Thanks, Helen, for that question. Working in the health and development sector, I am really, I just want to say and assert that health research and development is the core and center of pandemic preparedness. Without health research, really all the other things that we would put in place, whether health systems, access, whatever that needs to be in place, even if it is in place, if we don't produce our own products, if we don't produce our own vaccines, the next pandemic will find us in the same space where we have put in place all other things, but we still, as Africans, can't produce our own vaccines. So research refers to the initial basic applied research, clinical trials, it refers to product development. So if we are in that space where we can do that for ourselves, produce our own products, then we are on the right track to ensure that we have access when the next pandemic comes. But if we don't have that in place, then we're missing the point. So I think that's what I can say for now, that we need health research and development so we are prepared. Thank you.
Thank you, Sekile. Dr. Adrian, we are such a rich continent, not only when it comes to resources, but even brilliant minds on board. Why do you think the African continent was caught flat-footed? A lot of African countries were caught flat-footed. Sekile has mentioned that you need research when it comes to preparedness, but a lot of African countries were caught flat-footed. Why do you think this was the case?
For me, I would say that it's generally known that as Africa, we are losing close to $4 billion, I think, in brain drain. So this shows you that we do not lack the brains, but actually these brains we have that we can base on to develop our strength in R&D are employed elsewhere. So we need to develop a willingness, a political willingness to retain our personnel, because that is what we are going to build on to build our research. So when you look at, for example, in Uganda, we are having the national expenditure on R&D, which is just close to zero. It's 0.17% of our national expenditure. So this shows you that if we are not prioritizing our research, how are we going to retain the people we need for research if we are not really creating funding programs for them? So I think this should start from the willingness of the political fraternity, but the personnel we need to rely on are there, and they are actually working in some of the big farmers elsewhere.
All right. And to you, Maureen, Dr. Eridan happened to mention that funding is one of the key elements when it comes to R&D in any country as a means of being prepared. When it comes to closer home to Kenya and even East Africa at large, you partnered with the government for various research, even more so with the recent COVID-19 pandemic. And one of the key things that scientists actually happened to say, they needed money. How far are we in terms of the money that you happened to receive and the research that was put in place?
Okay, in terms of health R&D, we are at, as of 2019, we were at 0.8% of the GDP. We've been aiming at the 2% that was declared at Abuja. We are not yet there. Currently, we are conducting a study on to analyze domestic investment in health R&D. The results are yet to be out at the end of the year. But still, one thing that we suffer all the time when we are doing R&D advocacy, advocacy on domestic investment in health R&D is that sometimes funding is allocated to R&D, and then when the budget cuts time comes, that's the first target. And then in other instances, you find that funding is allocated, yes, but then when you follow up on how the funding was used, you find that it's a bit shaky in terms of accountability. Did it really go to health R&D? You find that the funding is diverted in some way when you follow up on where the funding went to. So that's what we suffer. And at the end of the day, that also now feeds into how come we are not able to be self-sustainable in terms of our own local manufacturing or our own producing our own vaccines, therapeutics, and diagnostics. Thank you.
As of now, according to the Abuja Declaration, which you so happen to mention, the cutout is 2%. Uganda, we stand at 0.5% as of now.
Uganda is at 0.17%.
17%.
And the rest of Africa is below 0.5%.
Yes. Now here on stage, I have Uganda, Kenya, and South Africa. Kenya, 0.8%. South Africa, 0.9%. What more needs to be done? Sakile.
We really need to push and advocate for more funding and accountability. Government's committed to the 2%, and we need to know what are the gaps or what is the blockage that is causing us not to reach the 2%. So I think COVID-19 has shown us that really there is more investment that is needed. And I think as advocates and people that are in the sector, we really need to make a case to ensure that our governments are able to mobilize the money and bring the money, because we will always be dictated to by the global north on how we are going to use research funds. So if we don't mobilize domestically funding for health R&D, we are at the mercy of the global north in terms of the type of, or the priorities of research, in terms of the amount that is given to us and protocols and everything that has to do with research. So if we don't mobilize our own funds, then we will be stuck and we will not be prepared for the next pandemic.
I see. Thank you so much for that. Maureen, there's a research that you managed to do your organization, and I would like you to just expound more and just tell us, why is it that when we experienced in preparedness for the next pandemic, during COVID-19, we saw a lot of instances of vaccine apathy? Why was this the case?
Okay, so there's a study we conducted in East Africa, and we're looking at the equity and gender barriers to vaccine uptake. And this was because at first we didn't have the vaccine, like it was limited. And then when eventually we got the vaccine, we found that the uptake was still low. So we're trying to find out what was the problem. This study was conducted in East Africa, in all the East African countries. And some of the issues that we found out was representation of women at the decision-making level affected how vaccine deployment strategies were made. Then you find that there were gender roles that affected vaccine uptake. So you find that if for the women who were not able to get vaccinated in good time, you'll find that they had other roles other than their daily jobs. So if there was no outreach or differentiated vaccine delivery approaches in their area, they would not be able to have access. Then another thing that played a huge role was the fact that most of the households are headed by men, being the breadwinners. If a man said, you're not gonna get the vaccine, and for whatever reasons, if they had their own reservations, you'd find that women would not go for it. So, and there are a lot of myths and misconceptions at the community level, of which moving forward, ensuring that there was education at the community level really helped in improving, in demystifying those myths and misconceptions. Those are just some of the, some of the results.
All right, I'll pose the same question to you, Dr. Adrian. There were a lot of misconstrued myths and misconceptions around the COVID-19 pandemic and when the vaccine even came to Africa. Why do you believe this was the case?
I would say that, to me, there was a lack of preparedness for the rolling out of the vaccine program in many countries in Africa. One case study that I would like people to benchmark on in preparing for vaccination is Israel. It managed to vaccinate close to 5% of its population in less than 2 weeks. But why did this happen? Their minister prepared for vaccination rollout before even they bought vaccines. They had a campaigning framework into public centers to enable people to be informed on every vaccine they were going to receive. They digitized data and the vaccine administration, whereby somebody did not need to go to the health center to receive a dose. He would just be called because the information was digitalized. So such a system helped them to distribute vaccines very fast, and as well to prepare the community to accept the vaccines. Then another thing which we fail to understand is the storage of these vaccines they were not designed for our healthcare systems. The majority of mRNA vaccines require ultra cold storage chains, which are way below negative 20 degrees. But when you go into many facilities we have can only store between 2 to 8 degrees and limited doses, by the way. But Israel managed to look into the packagings of these mRNA vaccines, redesign the packaging material to their terrain. So what does it show us? It shows to us that in the future, when we are planning global rollout programs, we need to develop Afrocentric approaches into their implementation. Otherwise, that's why we end up getting vaccines, which usually have a shelf life of 1 year. But when we receive them due to delays because of lack of capacity of local production, we receive them with a lag of close to 70% retardation time in registration, distribution, up to 6 months. So you have 6 months to distribute a vaccine in the remote area. Most of the times it will be expired by the time you do that. So we need to look at that in the future. And another concern is we are developing targets of vaccination programs which actually are not comparable to what our continents can absorb in terms of our financial muscles. For example, we were given a target of 70% to attain in terms of vaccination. When you look at the EU currently, which has a GDP of close to 18 trillion, they managed to have a vaccination program of 75%. But compare that to a country like Uganda, which has a GDP of 37 billion. We're having, I think, in this quarter, let me see, the rollout is 42%. So what does this show you? It shows you that in setting targets, why don't we be realistic in setting targets we can meet financially? I'm going to follow something pre-guided by a WHO, maybe planning designer, but what input or approach am I putting in there that meets my nation? So your muscle financially, your readiness in terms of infrastructure, accessibility, and availability of vaccines is not the same as the other people. So you will not be able to roll out your vaccine as you want. In fact, we've noted that even them, they reached 75%. We would have expected them to be above 95. So that has a lot to teach us.
And still on that, you said, as African countries also, one thing that we noted during not only actually even African countries, but majority, there was lack of sufficient data when it came to when the pandemic hit us. And even when the vaccines came, there was a slow movement on recording how many people have been vaccinated, how far have the vaccines reached. And this posed a loophole for a lot of African countries to get vaccines which had a short shelf life. And majority of the African countries actually disposed their vaccines because of, quote unquote, they had already expired before the vials had already been used. In future, how can we be able to avert such a situation? Sekile.
Well, I think the lack of data is, I think at that time, it was a novel virus, it was new, everyone was just still bewildered. African countries didn't know what to do. We were still looking up to the global north to find out what was happening, looking up to scientists. I think now that we know, it's easy for us to say, let's put the right systems in place. We have heard how digital technology and, saving up data and being able to, produce data and being prepared with strategies to ensure that people are informed in time. So those are some of the things that at least now we have the advantage, having gone through the pandemic, to say, what are we putting in place to ensure that we have the right strategies in place to inform people, to inform communities, to inform scientists and how scientists. And I know that at that time there were many scientists trying to produce a whole lot of data and information, but there was not even time to peer review some of the information that was being produced. And there was also that hesitancy to say, are these vaccines going to be even, effective, because we know that vaccines take about 10 to 15 years to be produced. So how do you come up with all the data that is needed in such a short space of time? But I guess these conversations now are there to say, what are we putting in place to ensure that when we are found or we are caught up in another pandemic, we already have systems in place, whether it's information systems, it's strategies to ensure that our communities are well informed, and we have scientists that are already well informed and know how to research and produce, reliable data. So I think this is why we're having the same conversations to say, let us be prepared with what we have now, with the tools that we have in place, yeah.
Okay, can I add, as Saki speaking, I think this should be a challenge to us as researchers and as research institutions to ensure that we share the data that we have, because you find that there are some studies that can be replicated in other areas, yet when you're looking for that data, you can't find it. And you know that this study was already done, for example, in Kenya, and it can apply to Tanzania or Uganda. When you're looking for those results, you can't find it. So I think we've learned that we need to share also across the borders. This is more helpful than everyone doing the same studies, trying to find out how to deal with a pandemic, and yet we already have such somewhere. Also ensuring that government institutions have the repositories that they can share with, let's say, partners or funders, yeah, so that we shorten the time of response.
Sakile, South Africa was one of the countries that rejected one of the many batches that had a short shelf life. And the scientists that were also involved had already begun their own research and development for COVID-19 vaccine. I believe there are a lot of lessons that we can be able to learn from South Africa when it comes to R&D and innovation. Could you kindly pose us here on the panel?
Well, there's so much that was happening in South Africa. We have the capability, but maybe we still need to build our capacity. That's one of the things that we are learning in South Africa. But I think there was so much to learn there, because while we had vaccines coming in, and then we realized last minute that actually these were now expired and we can't use them on our people. And I think that again was something that we really had to look into seriously, because then I think we tried to bring in a big pharma like Aspen and J&J, who set up a pharmaceutical or a manufacturing plant in Gqeberha, that is in the Eastern Cape. I think that one is a very sad story for South Africa, where we had a manufacturing plant, and secretly the vaccines were being transported to Europe. And we had only 7% of our population that was vaccinated at that time. And I think the New York Times exposed that in 2021, that actually the vaccines that are now being produced, and basically it was also a fill and finish kind of production, not even the actual development from scratch. So Aspen invested, J&J invested, but the vaccines now were going where? To Europe. And when that was uncovered, there was a whole lot of political back and forth between Europe and Africa, and our president had to try and negotiate that those vaccines have to come back. But then the other challenge was the fact that we didn't have any procurement agreements with other African countries. So we had these products that were there, they came back to Africa, but still there was no uptake, there was no one buying them. And eventually our plant in Gqeberha had to close down because all those vaccines were now expiring, no one was buying them. So that is one of the big lessons that we learned, that you cannot produce or develop and produce without having secured a market. So you have to have a secure market. And then secondly, the politics that come with the vaccine manufacturers, the agreements, you know, the multilateral, bilateral agreements that are made with big pharma and these big countries of the global north. Again, you have to clear that space first, because when we had this production of big doses and we couldn't even access them, And then there was that whole back and forth. And then I think finally the other thing was the fact that we need to ensure that we secure a domestic market and also funding, because again, this was Aspen, this was J&J, it was an investment by foreign companies into South Africa. And while we survived and the local companies survived, if it had been South Africa investing, we would have been at a big loss or even bankrupt. But again, those are the lessons that we're taking out as South Africa to say, let's secure markets, let's make sure that we clear issues of intellectual property, issues of trade between countries and so on. So I think, yeah, those are the things that I can highlight.
All right, Dr. Adrian, lessons from South Africa here from Sakile. She happened to mention that in as much as the country tried to start their own innovation, and you said as African, as a continent, we have to ensure that we know our targets, that we know even what exactly we're going to do moving forward. How can you gauge the quality management systems of African countries? Are we ready to produce our own vaccines? And are they going to be up to par, even to be accepted in the international markets from the pharmaceutical?
One of the key parameters tested in vaccine markets and the production is the quality management system of a facility. So I don't think we are gonna do any quality management system that is below the international requirements, because all regulatory bodies in Africa work according to WHO minimum guidelines. So there's no compromise on that. The challenge either would be, as she has mentioned, markets. Where we are as a continent, and what I've noted in production is there are some categories of products where we need to harmonize markets. And vaccine programs, that's one of them. In biotechnology, for those of you who have done biotech, you realize that for these biologics, some of the testing requirements may be hard actually to do in one nation. You can do a test here, you do another test in another country. So developing the quality testing protocols needed will take us time, both the regulators and the manufacturers, to invest. But it does not mean we do not need to do that. We need to set up precedents because we need access guarantees. However, another challenge which she has mentioned that South Africa grappled with, it managed to bridge a way of bringing big pharma to their plants to help in the production. But however, there is also a parameter of equity of access of these drugs. Because when you look at the majority of tests being done, trials are done in Africa. But when it comes to rollout of drugs, we are not given priority. And then we come and we complain to the whites that they are hoarding new medicines, new vaccines. So they are not actually doing any crime because they are prioritizing countries that will pay them better. However, we need to create policies that bind clinical trials in Africa such that you only do a trial in Africa with a mandate to ensure access and the availability of that drug upon registration, with Africa as a priority. Other than any creation of legal mandates, these laws will always be broken. So we cannot enforce the other people to ensure our equitable access to medicines unless we put it in law. So to me, that's what I would say.
And do you believe we'll be able to reach the PAVM agreement of 2040 and produce our own vaccines? Do you still think we're somewhere?
Yeah, I've gone through the methodology of developing the production of those vaccines, and I've seen that that rollout structured plan of making at least 5 plants operational in Africa. And when you look at its planning, it's actually realizable to make at least 80 million doses in the next, I think, 3 years. Then by 2060, we shall be making a capacity of around 280 million doses. So it is realizable. But now the concern is the investment needed in it. We need money that countries have to come up and agree to fund. Then also we need to develop a regulatory body that is able to do analysis and let me call it authorization for these vaccines. One entity in Africa cannot manage that. I don't know if South Africa really also can here. I know you're doing vaccines, but when we get into mRNA, it's a new ground where we are right now. So we need to think big. And then another concern, why we are also meandering and losing money in all these programs, it's because we are lacking an understanding of what are our specific targets. For example, you will create a budget of research and development funds, and anybody who tables any, in French we say n'importe quoi, I'm sorry, I don't know how to translate that, but it's, it's more of like anything that comes on table, you fund. But in other words, for you to benefit from the rights of your research, you need to know what are your strategic points of importance as a country, so that the majority of your money goes in that value chain. Otherwise, you're going to end up spending money, but with nothing to show for it as the end. So I think that also needs to be relooked into.
Maureen, do you have anything to add on that?
Yes, I'd say as he's speaking, I'm thinking about decolonization of R&D and decolonization of the whole process from clinical trials up to production. Another thing I'm thinking about is regional harmonization. So when you're thinking about manufacturing, we should not be thinking about Kenya. We should be thinking about the region. So we support the region such that if we focus our efforts on the region as Africa, so looking at it from a higher lens and not a country lens, if we get less selfish, we'll be able to achieve the local manufacturing agenda.
And Sakile, Dr. Adrian posed a challenge about South Africa not being able to, or rather, whether you'll be able to still do your own local manufacturing. What do you have to say about that?
We have the capability. We have scientists, good scientists. We have infrastructure, but obviously it has to be augmented. It has to be improved. We are in a space where we want to grow. We're open to growth. A couple of, I think, is it last year or the other year, South Africa was appointed by WHO to host the NMRA hub for tech transfer. So it's a hub within Southern Africa where scientists, and I think not just limited to Southern Africa, but scientists all over, all low middle income countries can come and learn and grow in developing products. So I think we are at a place where we all need to come together, as Maureen was saying, that we shouldn't look at it at an individual country, but we are looking at how, as Africa, as regions in Africa, can support each other, even if it's pooled funding for supporting a hub that will build capacity for our scientists. And we actually, I also like the issue of having an agenda of our priority areas. If it's HIV and AIDS, if it's malaria, those are the focus areas. But obviously, at the same time, building infrastructure and capacities in such a way that we are capable of even repurposing whatever we have put together. Should a pandemic come, we are able to switch. I think in South Africa, one of the things that we were able to do is the genomic sequencing in trying to determine what the variant was, and I think we were able to identify the Omicron. But all that came because we had the infrastructure. Even though some of the labs that we have were mainly for HIV, TB, and so on, but still we're able to repurpose those structures and facilities to ensure that we are able to start testing for COVID, just checking the whole processes. So I think being in that space where we are able to build our capacity, build the infrastructure, not maybe just for one thing, but it's part of the whole health system in our countries. Therefore, we are preparing ourselves. I think that's the move that we should all be taking. Hubs, supporting each other in terms of even funding and priority areas, and also being able to be versatile in terms of being able to repurpose whatever we have in case of pandemics.
Dr. Adrian, Maureen also happened to mention that it's time we work together as a continent and not keep research to ourselves. What more needs to be done to ensure when another pandemic happens, we will not be caught flat-footed, we will not be on our knees as beggars, but we'll have a seat at the table?
I think the pandemic has taught us as a continent that we need to bridge the gap of working as single nations. And I'm glad that programs like these have come up. They are sensitizing people on the way forward. African Union, Africa CDC is working under the same framework to develop a product registration harmonization initiative. And these are all good steps going forward. So regarding research, I think this has been a global problem. It's not just a problem for the country. And I think there is a website which was developed. It's clinicaltrials.org. So people were advised to publish their research onto that. So people were advised to publish their research onto that website to avoid the duplication of research, and that is actually helping. However, one thing that we are leaving out, we are focusing a lot on manufacturing, hospital and our health sector system strengthening, which are necessary. However, I've not heard of a program talking about the development of PPEs in Africa. We need to create capacity for making those N95 and those other masks that have a high efficiency of particulate, can I say? I don't know how to clarify it. It's more of like differentiating the particulate.
Different types of PPEs that are needed?
Yes, because we are not focusing on those. We are focusing a lot on 3-ply masks, which cannot actually be used in pandemics like that we've gone through for COVID. So look, going forward, I think we shall find ourselves later having everything in place, vaccines, hospital readiness, and then we are perplexed by how are we going to approach testing without protection. So as a continent, at least we need to plan on having at least one plant for those PPEs of the ones which have an efficiency of over 95% at least here in Africa. We need that.
Thank you for that. My last question before we wind up, to you, Maureen. How can we take your researchers closed up in your offices? It's time we take this information to the ground. How can we ensure, even in Kenya we call them, yes, the local Wanjiku terms, the Kamau, but how can we be able to take this information to the ground so that the people now can understand, okay, can the scientists tell us this information in a way that we can be able to digest and see that to prevent episodes, recurring episodes of vaccine apathy from happening again?
I think there are already some programs that ensure that we get to the ground with information. So in terms of getting to the ground, we also need to ensure we break down what, for example, health R&D means to Wanjiku, as you said. So when you break it down, you realize that someone will even be able to participate, for example, in a clinical trial or in a research, knowing very well what the end product is. Like they know the whole spectrum, they understand it better. But basically ensuring that we reach our people, and I think AMREF has several programs where we have education at the grassroots, and with COVID-19 we've been able to demystify quite a bit on basically the health R&D processes that we have here.
What would be your parting shot, Dr. Adrian?
My parting shot, I would like it to go mainly to civil society, because much of the agenda in driving the platform for vaccine manufacturing has been driven by civil society in advocacy on various levels and reaching communities, because this has shown me that they have a platform to access areas that most of the people cannot access, and they are pivotal in preparing the population, in advising government on policy frameworks, because the research they have is actually critical in advising on policy. So I would request more of government is cooperation with civil society in developing policies regarding the health sector?
Sakile?
Two things. I'm calling for more investments for our scientists and researchers for health R&D. That is where the core, the most important thing is for pandemic preparedness. We need to be prepared, we need investments, we need to support our scientists. And then I think one of the other critical things is that our governments should ensure that we are able to set and not allow big pharma to that have been developed overseas, and they come and experiment them on our people, and then they leave and our people don't benefit, but they've been the guinea pigs to experiment. The drugs are successful, they come back and they are very expensive. So we need government to ensure that whenever big pharma or the global north comes with requests for clinical trials and research, they ensure that there are policies in place to protect people and ensure that big pharma comes back and pays back.
Maureen?
Yeah, I'd say maybe government to follow through with their commitments. A lot of the times we have so many commitments that as advocates we are trying to follow up on in different fora. So World Health Assembly, UNGA, you find that the government will commit to something. And then when you try to follow up on how far this went, it sort of just disappeared. It's a declaration and that's it. Then another thing is to strengthen our national regulatory authorities in the different countries. So specifically for Kenya, I talk about strengthening Pharmacy and Poisons Board. This will also promote innovation, encourage the new innovations in the market. When the regulatory system is efficient, then the investors are encouraged. Then also promote local investment by putting an enabling environment for the private sector, making it easy for the private sector to invest, because I think there's a lot of money in the private sector, but they're shying away because of the measures that we have or the certain roadblocks that we have as a country or as different countries. That's a problem that you find everyone, like in African countries, talking about. Thank you.
Thank you so much, ladies and gentlemen, for your time. Ladies and gentlemen, just before we wind down the session, I can take a few questions, if anyone has a question for our panelists today. Thank you so much, Dan. We can take some questions.
Good afternoon. My name is Diana Nasike. I am from Uganda. I work with the National Public Health Emergency Operations Center. I've had a question that's been itching me in terms of research and academia, especially with regard to COVID-19. Repeatedly, it has been said that Africa, we are the poorest continent, and we have the worst public health systems compared to the rest of the world. But during COVID-19, we seem to incur the least deaths, notwithstanding the economic impact of the pandemic. But in terms of how it affected the health of the population, the impact was less than other countries. So my question is, has anybody investigated why that was? Why, in spite of the fact that everything was stacked against the continent, we still somehow managed to breeze through, relatively, the pandemic? And if research has been done, what was the result? Because Africa has solutions for the world, but repeatedly the discourse and the narrative is, we must pick solutions that are designed from Western boardrooms and bring them into the African context. Now, are the solutions valid? Absolutely. But what can present room X? Okay? So that's what I want to know. Yeah.
Thank you very much. I'm sorry I'm coming back again. Should have given an opportunity to someone else, but this is just burning. My name is Solomon Serwanja. I've done an investigation into research and development of vaccines in Africa. 3 things stand out for me. Many of you who are into this research sector know that research and development is very expensive. It requires human resource, and I mean the brilliant brains in the research world. Talking to some of the people who are operating these research centers, they'll tell you there's a lot of brain drain. The guys who have been, grown into molecular biology and into that research are being taken up by the big pharma. So we're seeing many of the guys who can do this work going for greener pastures. But also too, there's need for investment in equipment. And I think you talked about it earlier, that research requires, there's no return immediately. It takes time for people to come up with these vaccines. Uganda today is just doing clinical trials for COVID-19. And we're asking ourselves in Uganda, do we still need to invest money when we already have a vaccine? So we remember we are talking about the golden rats. There's the golden rat scandal where we were questioning why we would buy rats at how much? How much? Yeah, we spent a lot of money. But when you get into the science, people will tell you these rats are bred to have human-like, I don't know, I am not the doctor there and researcher guys, but they breed them to be like that. So the return on investment in research, we question, many of us want fast things, but the guys in the research world will tell you it takes time, give us patience. So we all throw ourselves on, give us accountability, we give you this money, can you show us the vaccine you've come up with? So there's this general slowing and political will to invest in like the equipment that is used in research, but also too, in providing the conducive atmosphere for these scientists to work. So I just wanted to speak about one thing. Is there a lack of political will? Because we know this. Why? Is an African Union concerned that this is where it all starts from, right? What can we do to push our leaders to think and tell them pump money into research and development? Thank you.
Thank you. I'll just have one more for this round, then we can.
Hello, everyone. My name is Margaret Nyambura. I am a health lawyer from the Kenya Legal and Ethical Issues Network on HIV and AIDS. That's KELIN. So naturally, my concerns would be on intellectual property issues as well as lawmaking. So I did listen to one of the panelists talk about strengthening our regulatory mechanisms. So in Kenya right now, I don't know whether there's anyone from the government in the room, we are considering the Kenya Drugs Authority bill in Parliament, and it is turning out to be a battle of supremacy between pharmtechs and fully qualified pharmacists. So on one hand, it could look like it's a supremacy battle. I mean, so many professions have experienced that before, but the question is, if the Kenya Drugs Authority bill is going to be passed with the amendments that have been suggested, which would have pharmtechs almost have the same capacities and obligations under the bill as fully qualified pharmacists, then that is going to jeopardize Kenya's chances of achieving ML3 qualification under the WHO pre-qualification requirements. And that would then mean we cannot get into local production, and therefore we will have a repeat of this once we are hit with another pandemic. So I don't know whether there's anyone from government in the room who can just talk to us about the processes of lawmaking and anything going on at the committee stage right now in Parliament as far as the Kenya Drugs Authority bill is concerned. My second issue would be a comment to what another panelist spoke about on intellectual property rights. So if you're going to speak about local production and you're talking about incentives towards private sector to contribute to R&D, then there have to be incentives, not just in the form of, tax exempt or zero rated production. You also have to speak to them about compliance with WTO and WHO laws. So for instance, TRIPS. So TRIPS is the trade-related, it's a law on the trade-related aspects of intellectual property rights. There are some provisions of TRIPS that support public health. But we usually have bilateral agreements and foreign trade agreements that have included TRIPS plus provisions, which then choke the possibility of any developing or low to middle income countries' chances of participating in local production. Because then, if you're going to have, I don't know, this sounds a little bit complex because it's about patent law, but if you don't have incentives all the way from intellectual property, we cannot have a conversation on local production. So beyond the hub, the one that's in South Africa, and the other spokes, because I know there's a hub and then there's spokes. So beyond that, do we have other avenues for technology transfer? Because I know countries, especially developed countries, are not crazy about tech transfer. TRIPS itself does not have any requirements that are obligatory for countries to do tech transfer, whether you're in a pandemic or not. So how do we balance the commercial interests vis-a-vis the human rights interests so that we can have access to medicines? And also, if there's anyone else in the room from government, we had COVID from 2020. 2021, 2022, we passed the legal notice on recordation of pharmaceutical products alongside all other products. So recordation processes themselves are another barrier, they're a bottleneck to access to medicines. So how is it that we are going to start talking about what have we done since COVID, that is to support access to medicines and promote local production, yet we are passing laws that are mostly leaning on the commercial element, that is like the recordation requirement, as opposed to promoting access to medicines. Thank you.
Thank you very much. I think we'll first of all respond to those, then we can pick maybe one more round and close.
All right, thank you. We can start with you, Sekile.
Okay, I'll respond to the first question on how Africa avoided or was spared from the catastrophic deaths of COVID-19. It's a very difficult question to answer. I think working and being in engagement with scientists, those are the questions we would ask daily. What happened? There was the whole prediction that Africa would be a place where we would be burying people every day, seeing as we have slums, we have all these, poor health systems. But it didn't happen, except South Africa suffered the highest, I think with over 100,000 people dying from COVID. But checking through all the other countries, I think we had less than 5,000 people dying, if I'm not mistaken. I'm not sure if there was any other higher number than 5,000. But South Africa, it was 100,000. Initially, there was arguments that there was not enough, data, or people were not reporting, people were not being diagnosed. And the other argument was that, but his hospitalizations do not lie. The number of people going to hospital and being admitted and dying, they do not lie. And I think many African countries can attest that, well, the numbers were there, but they were not as bad. So again, it's something that I think some research is still ongoing, unless there's someone that has come up with some kind of research. I don't know, but research is still ongoing just to find out how Africa escaped. It's still a mystery even up to today.
So I have something to add on to how we escaped. I think we also, as much as we weren't prepared for the pandemic, we must appreciate that we were more resilient because of some of the things, some of the systems that we already had. For example, research has found that the community health strategy, the areas that had a community health strategy well established, were able to even, they had even a higher level of vaccine uptake. So we must appreciate that we just didn't know that that is what would help us also. But then we were somewhere in terms of our resilience, or how resilient our health systems were, only that we were not there yet. So it's a lot of things around it. Maybe our research needs to be done comprehensively that answers all the questions that we usually have on this.
Okay, enough has been said regarding the deaths. I won't elaborate more on that. However, I'm going to address the concern regarding the political willingness of R&D. The challenge we are facing with our political leaders is because they are slowly beginning to understand its importance. Before, I think they didn't understand the gravity of this. However, the coming of COVID has been a game changer to all of us. one of the things I need to elaborate to you as to why research is important. Any nation that does not invest in the research of the interests of its country is going to end up either begging or entirely dismantled out of the global economy. Because I can give you an example. For example, India was severely hit by the supply of active ingredients for making drugs. So what did the government do? The government sat down and it said, we are going to categorize 10 APIs. The government created a budget of $10 billion to put in research. India has close to 35,000 manufacturing companies, but none of them can make, I think, $10 billion. So you see the magnitude of what it takes to go into research. As a private entity, you may not manage the financial muscle alone. So there has to be government support. So when we look at the ongoing concern regarding climate change, the US has set aside massive amounts of federal funding for corporations to transition into clean energy. And this clean energy is going to come in the future to bite us. We will not be allowed to export products probably there unless we demonstrate that we are actually using clean energy, of which it needs money. A single company may not be able to do that. So how do we catch up? We need to understand that we shall not be benefits of donations because it's not sustainable. The pandemic has shown us an example. So political leaders need to wake up and understand that the driver for their national economy, accessibility of resources and some of the items they need to invest in the R&D for it. We need to have a game in that market. I could not elaborate it more clearly with the pharmaceutics, but at least with things that you see along climate change, they are going to be heavily impactful. So I think that's what I can say on that.
All right, I think there was a question some should ask about if there's anyone from government who can respond to. I'm not sure whether, I think he left. Sorry?
There is another question our colleague mentioned.
Yes, some of which may not be from government, but would get insights on the same.
Okay, I will not answer for the Kenyan government. I'm not a Kenyan government. But at least I'm going to try to make it clear for you how to evaluate between commercial interests and human rights. In the management of a business, you all work for a profit and for any problem solving, I would say. If a problem to be solved regards human rights, anybody who's designing whatever that product could be or service will put that into consideration. However, when we look at what we are discussing on, for example, manufacturing of pharmaceuticals in general, so these are manufactured to the benefit of health and also for commercial interest. So, and globally, as we know, for you to be able to sustain the running operations of whatever you're making, you need money. So the balance of human rights to money, trust me, most of the people will tend to follow the direction of money. We know that. But it does not mean that we totally outdo with human rights because we need them as well. So it's a complex balance, but to guide you better is money will always be the driving factor.
Thank you. Dan, can we take 2 more questions and then
Yes,
we
can
close?
take 2 more. And I will prioritize those who had not raised, who had not spoken before.
All right.
Solomon was a very lucky one when he raised his hand. So let me pick someone from these guys had spoken. I'm trying to be democratic. I'll give Mwinzi, then I'll give one gentleman from that table. And I request that we keep our questions brief because that is what is holding us from lunch.
All right, I'll not be the one standing between you and your lunch. I'll keep it very short. My question goes to you, Dr. Kivumbi. I've been listening to the panel discuss whether we are ready for the next pandemic. And I've listened to you talk about cold chain preparedness, whether we have done anything with that, whether we've improved the infrastructure around that, our vaccine manufacturing capacity on the continent, and whether we have the right policy postures for the next pandemic. And I'm still not convinced whether we are ready for the next pandemic. And my question to you is, are we sleeping on the
Thank you, and I'll cross over to this side. Lunch is a step closer.
Thank you so much. My name is Kafero Herbert. I work with Siatini, Uganda. I'd like to find out from Ms. Sakile, you talked about African countries setting their research agenda, but I'd also like to inquire from you, how can we align national health needs with donor priorities? And then the other is around the Global Health Security Agenda that was launched in 2014, and also the International Health Regulations that were adopted in 2005 and entered into force in 2007. They spell out core competences and capacities that countries should adopt. What's the missing link from your perspective? Thank you.
Thank you very much. We can now take those as we come to a close.
Okay, aligning our national priorities for research with donor. Oh my God. I think our government is really responsible for setting the scene and ensuring that any donor coming in, there are already structures in place. In South Africa, we have a institution that's responsible for our research and also setting our agenda. So we have the South African Medical Research Council. There we have priorities. So most of the donor funding comes through to MRC, and it has whatever funding that comes, it has to align with our research priorities. So it's very important that our governments play a leading role, our departments of health, to ensure that they state clearly what the priorities of the countries are, and ensure that when donors come, we are not just handing out our hands to say we receive whatever donation, because then they will be asking us to research about issues that are not a priority to us, and we will end up researching because we want donor funding. And also the institutions where donor funding goes to also have to align with what government has set as priorities. Otherwise, we have institutions, obviously, that want to make money. We need jobs. We need to be paid. And whatever the donor says and says, here is money, can you research about something that's not a priority, do clinical trials on our people, on things that are not a priority, then that is where we suffer. So government has to play a key role in setting the standard and ensuring that there are policies where big pharma donors go through that in order to be aligned with what countries have in place as priorities.
Okay, let me address this question concerning how ready are we as Africa for the next pandemic. In my simplicity, I would say that to approach such a question, you have to look at 3 categories. For example, on the vaccine platform that we are talking about, there is an area of vaccines access. There is an area of preparedness for pandemics, and also vaccine research. So you have to ensure that all those 3 areas are strengthened. The area of vaccines research takes years. As Mr. Solomon was telling us, you can put money in research. Actually, on average, it can take even 10 years on average. But however, as we are strengthening our funding in that area, we look at what we have and how do we strengthen our systems around what we have. So we have infrastructure like hospitals. How do we prepare these for receiving people with diseases that are contagious? I would ask one simple question. Many of you have served in hospitals. Have you ever found a hospital with a demarcated quarantine area where you are sure that there is no mix-up of air from the quarantine area into another common access area? You find the hospital just demarcating an area as quarantine, but actually the conditions around it are not for quarantine. So what does this mean? It means that we need to look at our systems and how do we strengthen them, because these are now the simple things we can do, and we do them now. So we strengthen the infrastructure, the equipment, the way we design our hospitals. Then we focus on the accessibilities to that infrastructure, because it will not help for you to have a hospital in the center of Nairobi, and somebody is living at the far end of the country. he won't access it. So surely many people will die. So how are we strengthening accessibility to our infrastructure? Is it equipped? Are there enough personnel? Are there people having the protective gear they need? So these are the simple things which we need to ensure that we strengthen for now. Then the other concern which will come in later will be like the availability pillar. By availability, I'm going to look at the medication necessary. How continuously available is that? Do we have a system in place to ensure that we have multiple suppliers? Are we having local production capacity? So if you are building local production capacity and then you get concerns of limitations because of IP rights, that's where your R&D strengthening comes in place. So this, to simplify it to you, that we need to relook into where we are and what we can do about what we have, then we think broadly ahead to bigger issues like R&D and the local manufacturing.
Thank you so much for your time. I believe, ladies and gentlemen, that was quite an insightful conversation. And if any one of you would like to see the panelists after, you can engage with them during the lunch break for more questions. This has been a beautiful session and an engaging session. On my right-hand side, Mrs. Sakile, Ms. Sakile Kaweka, thank you so much for your time. Maureen O'War, thank you so much for your time. And Dr. Adrian Kivumbi, thank you so much for your time. Thank you, Dan. You can take it away.
Thank you very much, Helen, as well. And as we take a break for lunch, I'll just let you know that when we are back, we shall be having 2 panel discussions which are going to be moderated by our sustainability editor, that's Zainab Wandati. And what they are going to be addressing, one is the role of civil society in shaping and driving political accountability for equity in PPPR, which is something that has partly been mentioned in the discussions that have been ongoing. So you could see how interconnected these matters are. And the other one will be the role of media in shaping the mobilizing and sustaining political accountability for PPPR. And we shall be then having our closing remarks after that. So for now, you're invited to lunch. I believe everyone has a meal voucher. In the event that you do not have, I think everyone has a meal voucher. I believe so. So you are invited to lunch. It is now 1:20. I will try not to give you pressure that you may choke, but that may be the next pandemic here. But I humbly request that we have ourselves congregated back here at 2:20. All right? Those of us who eat slowly, and I think there's a thing about you have to masticate. Today might be an exception, but just be careful. So you're welcome to lunch. We see you after that. Thank you. of civil society in shaping and driving political accountability for equity in PPPR. The role of civil society in shaping and driving political accountability for equity in PPPR. And our moderator for this panel discussion is our sustainability editor, Zena Bondati, who I now welcome to the stage.
Hello, everyone. Are you feeling good? Mumeshiba. In Kenya, we say mumeshiba. Mumeshiba. Have you had enough to eat? We welcome you. For those who are coming to Nairobi for the very first time, Karibuni, Kenya. Unfortunately, you've come at a time when it's raining, so you're not able to see the beauty of the city, but just down the road, we have the Nairobi National Park. It still has sights for days and views for days. So welcome to this afternoon discussion. Unfortunately, I'm coming right after lunch, so food is digesting, your body is starting to get tired, maybe you want a siesta, but I promise you're going to have an exciting discussion. Now, my name is Zena Bondati, I'm sustainability editor, and I work a lot in the climate space, the agriculture and climate space. And one thing that's very common in that space, or very key in that space, particularly the climate space, is the civil society. The role that the civil society groups play in shaping the climate conversations and in pushing governments to deliver on the commitments that they said that they would. So now we want to have that conversation. What does the civil society look like in this pandemic preparedness and prevention and response conversation? And to have this conversation, I was to have 4 panelists, but one was not able to join us. So I'd like to call up Agria Luso, who is the Africa Director and Global Policy Lead, Pandemic Action Network. Karibu Sana Agri. Thank you for honoring us with your brilliance and your presence this afternoon. And I'd also like to call up Abdul Karim Muhumuza, who's the Head of Partnerships and Communications, Afya na Ahaki. Karibu Sana. And last but not least, Zakaria Kafuko, Director, One Day Sooner, Africa. Karibuni Sana. I'm the only pretty face up here. But all you have to do is just keep your eyes on my pretty face. That's all. Just keep your eyes on my pretty face and you'll be okay. So we'll take the space of any other wonderful lady who could have been here today but was not able to. Now, gentlemen, welcome. Karibuni Sana to Kenya. So I'd just like to get right into it. We have about an hour in this conversation and I'm hoping we'll have some time for question and answer at the end. So I'd just like to get right into it, starting with you closest to me here. What is the role of civil society? I believe your microphones are all on. Your microphones should all be on. What is the role of civil society in this conversation of pandemic preparedness and response?
Yeah, thank you very much for welcoming us. It's not my first time in Nairobi, but it certainly always feels like the first time. So my name is Kafuko Zakaria. I'm the director for the African chapter of One Day Sooner, and we advocate for the use of clinical studies for vaccine development. So maybe to get to your question, I think when you think about vaccine development and generally speaking, pandemic prevention, preparedness and response, think of it like a machine. We have the researchers, we have the government on one end, policymakers, and ultimately all these should be servicing the populations. But within that machine, there are other parts that need to be moving for it to actually work. And civil society organizations bring that missing link because majority of times, and I don't think anyone here needs to be reminded that sometimes governments are very good at being politically correct, and then afterwards it ends there. So there's always need for checks and balances, and especially for accountability. Now, civil society organizations, number one, present a very unique power and moral authority to remind the commitments that have been made, to hold the commitments to account, and most importantly, I think civil society organizations speak as a balance from the community. When they have been in these communities, they've seen the depth of problems,
the issues that are going on, and they bring that picture when they begin to talk about some of these things. So the civil society organization brings otherwise the voices of people that may otherwise not be able to stand and face authorities. And also civil society organization has also a rare and unique role to also represent some of the views of people within the machine. For example, researchers that work for governments, for example, they may not always have the latitude to speak directly in face of their employers. So this is where civil society organizations come in and take the microphone to represent the voices, the communities, to ensure that there's accountability, to ensure that things are moving in the direction they should move. Thank you.
Thank you. So, Abdul Karim, I'd like you to pick up from where Zakaria has left. He mentioned that governments are very good at giving lip service, and that civil society groups then come in to bridge this gap. So speaking of lip service and being politically correct, we just recently had the Africa Climate Summit. And we keep saying how health is a very important aspect of our lives, and climate change also affects health. But if you look at the results of the Africa Climate Summit, the Nairobi Declaration only mentions health once, and it's in passing, in just one clause, in passing. So how can then you hold political leaders accountable if when they sit down to make decisions that should affect our lives, they don't even mention health?
Thank you very much, moderator. And I thank again NMG for hosting us here in Nairobi for this wonderful but very important and timely conversation. So just to add on what my colleague Zakaria just mentioned, as civil society we have a critical role we play in ensuring accountability for pandemic preparedness, prevention and response. I'll give you a classic example that sometimes we are on the side where we are saying, government, you're not doing ABCD. But at the same time, we sit with government on the round table and we say, this should happen like this. So we are not always on the other side where they say we are noise makers, but also sit on the round tables with government, with different relevant institutions, and have these conversations on the gaps, on the things that are not giving sight when they are programming and planning. I'll give you a classic example during COVID-19, when government was busy looking on how do they respond to the pandemics. They had forgotten about the public health law. Our public health law was initially in 1989. You can see those years until the pandemic happened. So we had to sit with government and say, there is a room for using this public health law to put in place measures that you can use to prepare for the government. But also, as we are rushing to give vaccines to communities, they were not thinking about hesitance. People were saying, no, you cannot vaccine us. You cannot give us vaccines. They had their own reservations, their own issues. So we worked, I'm happy Agri is here, worked with Open Society Foundation then and said, why aren't people accepting the vaccines? So we went to the communities. Community participation, very critical in programming and planning for our countries. And we're asking them, why aren't you taking on these vaccines? Something government had not put at the first place in terms of planning. So sometimes they tell us they are overwhelmed, sometimes there's limited resources, but we come back to check on them. So as civil society, we have, I could summarize into 3 major roles. One is on evidence generation. We have a big role we play in terms of ensuring that we generate evidence, and this helps us to interface with the communities, but also understand what programs our governments have put in place, where are the gaps, what are the strategies that need to be improved. So through this evidence generation, it then helps into understanding the landscape, also understanding the perspectives of communities, which government should put in place. And then the second element is around capacity enhancement. You'll find that in most cases we've had issues where the programming lacks the element of capacities in terms of how they do their programming. So we come as an interface between government, between CSOs, between the media, but also the grassroots communities, to have dialogues, to have conversations, to know where are the gaps, where do we need to add more efforts, where do we need to improve in terms of the programming. The last bit is around evidence-based advocacy. You will see that we sit at the back But then we see government running with very many initiatives, many laws, many policies. But then our mandate is now to come back and say, you are running with this policy, with this law, but you are forgetting the element of investing in it. So in most cases, we've done a lot of policies, a lot of legislations, but there is less commitment in terms of resourcing, in terms of human resource and financing itself. So we've been always at the doors of our government officials that we need to invest money in these initiatives. So being on these roundtables, being part of regional spaces and conversations, very many initiatives. The PAVAM framework of action has a clear target. By 2040, we should have had, Africa should be able to produce and supply 60% of its own vaccines. And today we are at 1%. Okay. By 2025, we should be at 10%. By 2030, we should be at around 15% of production of vaccines, but we are still at 1%. So we can't sit and wait for government to keep planning and planning and planning. But also, we have so many other initiatives. The AMA framework, we have the pandemic treaty conversations are ongoing, the pandemic accord. We have to sit in these spaces to make sure that the components of equity, the components of the human rights-based approach are incorporated in these treaties and the different strategies that are being put in place, so that to ensure that at the end of the day, whatever the governments are planning are for the better of serving the communities, not necessarily putting in place and ticking off that you have this policy as a country, we have this strategy, but when it is not serving the interest of the community. So we come in those aspects to ensure that we put government to task, we remind them that as you are busy in these regional and global meetings, sitting there to discuss important things that concerns our citizens, make sure you have quality input. Make sure that you are putting in place things that are going to benefit our communities. But also ratification. For instance, the AFCTC, the Africa Trade, for instance, our country has not made a ratification on trade. And we have very many gaps around trade and the flexibilities that are affecting, for instance, local production on our continent as Africa. So how do we push governments to be able to, one, ratify these commitments, these strategies, but also put in place strategies and resources for the implementation? Thank you.
Okay, agree. Quick question. Can you cite instances where the civil society has actually played an active role in shaping the conversation or getting the government to be accountable in pandemic preparedness? Any success stories that you could cite?
Thank you very much, and I think you've asked the right person that question. So first of all, just as a way of introduction, I work for Pandemic Action Network, which is one of the post-COVID or the COVID era organizations. So our the trigger that necessitated formation of Pandemic Action Network was really to break this cycle, this very predictable cycle of panic and neglect. So whenever we have pandemics, we get into action and we are running helter-skelter. You know, and we've had several of such cycles. We had the Ebola in 2014 to 2016. We've had the MERS, Middle East virus. We've had you know, all different forms of outbreaks, including chickenpox and you know, and swine flu. And every time we have this predictable cycle of people getting into a spin, and then when things settle down, we go back to our usual siloed or complacencies. So one of the things that we have invested and which we've done quite a bit of doing, and a number of organizations who are here are members of Pandemic Action Network, so it's not something we are attributing to ourselves, it's the collective. Our existence is really about driving collective action so that we break this cycle. So it's not one, recognizing that no one entity can do this by their own. And therefore, we bring everybody on board and bring that political capital to make agendas that are critical for human interest to be part of the policy discourse. So that has yielded quite some fruits, but not to the extent that we want. So I'll give an example. It's good, my colleague from Uganda here, whom I had the privilege of working with when I was at OSF, I had the opportunity to support a number of initiatives around COVID response. And one thing we did in Uganda, for example, at the height of pandemic, when people were dying, you know, in hospitals, gasping for breath, and Probably they just needed a simple support with access to oxygen. We worked with a journalist, for example. He was to be here, but he's not here. Daniel Kalinaki, I think, who works with your group, and fed onto by colleagues from the CSOs in Uganda. And they developed a powerful story in terms of how people are dying, preventable deaths, just because they could not access timely, ventilators and oxygen. And I think the Ugandan government swung into action. I remember there was a mobilization of the military, for instance, and others to join forces in ramping up the capacity to produce medical-grade oxygen. So that was an example, for example, of how highlighting, bringing the human face to these issues, can help create a different trajectory of how governments respond. And that's a very critical function of the CSOs. We are very important agents of agenda setting. If you leave governments to their own, governments are not innocent entities. They are beholden to a lot of interest. I'm sure we all appreciate that. And we've seen a lot of policies that look good on paper, but you find there's a vendor behind that policy. So we have a lot of vendor-driven policies. The very health sector, for instance, is a multi-trillion-dollar sector with a lot of vested business interest. Public, imagine most of the decisions are made for their sake, but really a lot of decisions are influenced by people behind the scenes. So civil society organizations have this important role of really challenging the undemocratic pursuit of policies or formulation of policies, and make sure that those policies that are being made by government are those that are actually for the interest of the public. It's something that I can't say we've had a lot of success in, but I'm happy to see colleagues, for example, from People's Health Movement, whom we've worked with to really unpack and really reveal some of the powers behind these influences. For example, you may recall in Kenya, some years back, not very long ago, there was a proposed PPP arrangement with, I think it was Apollo. It ended up in court, so it's in public domain. And a number, I think Elaine is here, and a number of organizations who went to court to challenge that arrangement. Because PPPs are always framed as this savior, and they are for public good. Yet they don't have access conditionalities that would ensure if government invests in a public-private venture, that the benefits accruing from it will be extended to the citizens. And we've seen CSOs using different tools, including strategic litigation, to help advance equity, and a number of many others. And so I think the important role of CSOs is really to also deconstruct some of the prevalent narratives. And that one we do collaboratively with the media, because health, like I said, is a epicenter of a lot of competing interest, and every sector that has interest in it, or every actor that has an interest in it, would want their version to be the most important. And of course, in Kenya, you know about the MES, the Managed Equipment Scheme. It's in public domain that the National Assembly, or the Senate Committee declared it as a corrupt enterprise that was designed to siphon money from public coffer. And that is what it was. Yet nobody had seen that. And civil society organizations saw it from the conceptualization, that there is no way you can come up with an idea that has not been informed by public or popular participation and say, I think what we need are ICUs. And we see this permeating a lot of policy decision making. In the so-called UHC, which is a very important integral factor, factor in the pandemic preparedness and response. Because if you have a resilient health system, we'll be able to detect pandemics and contain them before they detect outbreaks and contain them before they become pandemics. You need a very robust, active health system that has good surveillance capacity, that has resourced human capital, that has equipment that can do genomic sequencing, for instance, so that we are able to timely detect diseases before they become outbreaks. In Uganda, for instance, you know the Ebola outbreak, and I know the director is here. And this is something we have acknowledged and we keep building. The period it takes from the first case to the, from when a disease starts percolating in a society to when it is now actually identified as, this particular disease that needs this particular response, still takes a very long time. And that makes the whole difference between a pandemic and an outbreak. Because not all outbreaks have to be, to be pandemics. And ideally, all our, pandemics can be all prevented if we can have a resilient health system. That's why UHC is very important. But you see, our UHC is very curative heavy. Whenever you're thinking about financing, it's about, oh, let's consolidate our resources so that when you get sick, you go to hospital. When you get sick, it's already too late. We need to support you not to be sick. Government don't have contract with hospital to provide sick people, but we behave like they have contract to provide hospital with sick people. And we need to challenge those kind of narrative because that is a vendor-driven narrative that is curative. It's capitalist model, which looks at how we can best make profit. You don't make profit by prevention. You make profit by selling medicine to sick people, by putting them in hospitals. That's why you see a lot of our policies are very curative heavy. And civil society organizations have the responsibility, together with the media houses, not to just follow government declared policies, but question them. What is the rationale of this? Why don't we invest here instead of here? If we were to prevent people from getting sick, we would have better economies, better efficiencies argument, other than waiting and to pay for them when they're already sick and dying. So those are some of the important, the other side of conversation that civil society needs to do. And those of us on the demand side, so civil society organizations mostly work on the demand side of things to help create those kind of vigilance and to help, sustain accountability like our colleagues have said, but more importantly, just to give the third eye and not just accept things the way they've been framed and put to us.
There's something you mentioned about how the civil society groups had seen what was wrong with the MES system, and yet the government still proceeded. And so I'd like to throw that question here to Zachariah. Given that the civil society groups can see when a system is broken somewhere, but in generally civil society or groups are looked at as noisemakers, a bother, you're a tree hugger, you're a this, you're an activist, you're this, you're that. Nobody really pays attention to you. So how then do you get them to pay attention when it comes to pandemic preparedness? Because if you take COVID, for example, COVID came at a time when nobody knew what it was. Nobody knew where it came, and there was so much being said about it, so many myths, so many misconceptions. How do you navigate those murky waters and the perceptions that governments already have of you as civil society?
Yeah, that's a very good question, I think, and you're not wrong. Majority of times, people in the civil society space have labels, and these labels won't go away nonetheless, right? So maybe to think a bit more critically, like I mentioned earlier, for civil society organizations, the focus and the drive is the benefit to the people, the benefit to the communities, to the population. I think as long as this is maintained as a focus, it makes a lot of what needs to be done maybe quite easy, maybe not perfect, but quite easy. So speaking of the specific situation with COVID, for example, for me, as a person, for example, I got a lot more engaged in civil society space because during COVID, hundreds of people every day, people that we knew, people that we could see in the communities were getting infected, some were dying. We were in a place where nobody seemed to know exactly what was going to happen the following day. And the sad reality, especially if you are experiencing that and you're in Africa, the sad reality was that there was no solution in sight. Not funding, not coping, nothing was available. So all eyes were on the West or the global North. So in the meantime, what was left to be done for a person like me, for a person like him, for a person like you who is in Africa and you haven't seen any investment, there are no research facilities available, so what needs to be done? So a lot of the navigation from our perspective that happened, especially during COVID, was driven by the scale of the problem itself. I think most of the times leaders only begin to pay attention when the population begins to cry out along the voices of civil society organizations. Many people were, struggling, and like he has mentioned, people are losing lives for things that really shouldn't be an issue. Imagine the healthcare workers who had to go to the health centers every day without PPEs. Think about that situation for a minute. When everybody else was locked in their houses, being comfy and scared, the healthcare workers were expected to go out and attend to the sick for a pathogen that we had very little knowledge about. So you can see the scale of the problem from that perspective. So basically manifesting itself in that way and amplifying the voices of the problem itself was one of the perhaps easiest approaches that we have used. Myself, I actually signed up to participate in a COVID clinical trial during the pandemic. And it was not as a matter of, I don't know, in retrospect now, I don't think it was even a matter of me trying to be a civil society activist or anything like that.
It was just you as an
I was
individual.
just in a position where I saw people getting infected, I saw people getting sick. And the question that came to my mind was, my mom is asthmatic. And I was asking myself, what would I do if my mom got COVID, knowing full well that there's no oxygen in the hospitals, healthcare workers are hard to come by, health facilities are substandard, and all these many questions. So the situation itself was dire. And in as far as navigating and even sort of making noise, even while you carry the label, sometimes it's either you keep quiet and become a passive supporter of the loss of life, which should be preventable, or you stand up and speak. I think that should be as easy a question for anybody as it is. Of course, there are so many ethical considerations that have to go into this, but as long as the focus remains that all the work that we do, all the work that is going on, especially for civil societies in Africa or in other poor regions of the world, the focus is really trying to help people, trying to help communities. And I think this, in many ways, remains and should remain a critical focus. This, I think this also, if I may add, leads to another aspect of the work in terms of navigating some of the murky waters, as you called them. Sometimes civil society organizations will find themselves in a position where the very forces you're trying to fight against are trying to bring you closer than necessary. Right? You begin to create conflicts of interest and biases that may begin to water down what you really wanted to say into something that maybe resembles political correctness. And that's why I think it's important. We have some work we're doing, for example, with the People's Vaccine Alliance. And one of the critical things with the People's Vaccine Alliance, for example, is that you must declare that Big Pharma and you have no working relationship, right? Because if we're going to be fighting for access to vaccines, and the people, for example, that are funding you are Big Pharma, how in good conscience do you navigate those waters? So reducing the conflicts of interest, reducing personal biases in the work, I think has helped a lot in terms of the general work of civil society organization. But like I said, by many standards, the focus should, and as long as it remains, the community and the benefit that community is scheduled to have from our involvement, from our speaking up, from our calling out the wrongs as we see them and as the people see them. I think we can navigate those, even though that means carrying a label most of the times.
Yeah. Oh, you want to say something about that?
Just on that, you see, I want to use a very simple, common example. When you go into a marketplace, you're either going to buy a product or you're going to sell. Some people go for window shopping, but you know that on that day you're going home with nothing. So if you want to engage government, one, you have to build trust with them. Same as if you want to have a long relationship, you must build trust. You must have something you're bringing on the table to have that confidence, that trust in you, that you have some level of influence. Same as us, what we do as civil society. And our power is always around reason. And we did research and sat and told government, this is not meeting the current situation and the future pandemics that may come. The legislation was amended and passed. We went to communities and did research on vaccine hesitance. That has shaped programming on how the government has to go back to communities. So you must have something you're putting on the table in order to gain their confidence. But also, however much our government officials are very political, we have their very, I don't want to use a word that might be offensive. We have officials who are understanding, who put a human face into things, who are touched, who feel the pain of the communities on a program of work for the last 1 year. We've been looking at how do we advance local vaccine manufacturing, looking at the DVTs, the diagnostics, vaccines, and therapeutics. You go to facilities, there's nothing to be used. So if you don't get your leader and take them to the community, to the facility, and they see what is happening, and you tell them next time don't come back for our votes. So the power of convincing communities, and that's why I mentioned the point of community participation. That's also the power we have as civil society. We rally communities, we engage communities, we get information from them, we give them feedback, and they support us when we engage in these communities. Another thing, like I said, we're an intermediate. We link government to civil society, to the media. And you can see in presence. You must have a journalist in your meeting if you want your issues to reach the public. And that's how you influence the public. So also, our element of capacity enhancement, like I mentioned earlier, is also a huge tool that we've used to influence the government in terms of their programming and the implementation of various strategies and measures that they're putting in place.
You mentioned community engagement, and don't you think sometimes the community itself is the weak link in this space? Because as an African population particularly, we are known to criticize everything but our leaders. We will criticize the bread you want to buy, like you told me this bread is 400 grams, but I went and tested it, it said it's 359 grams. You told me the preparedness or did not prepare me for the pandemic, I'm not going to say anything. So don't you think maybe sometimes the community is also the weak link?
I agree with you and also disagree. The community becomes a weak link when they are not informed, when they don't have the right information, when they are not empowered. And that's another contribution we've been doing as civil society. We sit in boardrooms to write proposals. And I use an example of Agri at OSF. Agri can explain how it takes us to get this money. 6 months, you are writing a proposal to get a grant of £1 million shillings. 6 months. But at the end of the day, you want to go to the communities, to speak to them, to get their information, to understand what challenges, what issues they are having. And then you bring these issues to the national level, to the regional conversation, to the global conversations to be implemented. So once you empower the communities and you give them the relevant information, that's why I told you media is another very strong component. We've done investigative stories. We've done very many documentaries that are coming from the community voices. The work we did with Solomon, AIJ, that documentary here, which set the ground this morning, we presented this documentary where we even had government officials, but some of them were even surprised that these things are actually, this is the status quo of our continent. You see, the subject we're discussing is very technical to the extent that even some of our government officials don't really internalize some of the aspects that we are discussing today. So having these pieces of work, these documentaries, these policy briefs, these research studies, and these roundtable conversations with policymakers are very critical. And I think as civil society organizations, we have an upper hand.
Prevention and response in Africa. What does that journey look like for you as civil society as you advocate for equity and accountability?
All right, and allow me to also just say something about what my colleagues have talked about, and then community and what civil society can do to really shift the needle. Because we recognize a problem. I usually say the point of departure is if you're the only one who is seeing a problem, then you are the problem. Yeah. If you want to make it a real problem, then many people have to see it as a problem. So really mobilizing many people to see that problem as a problem. That's why the community here is very disinterested, very disconnected. We did a study when I was at OSF around really what makes people not to be engaged and mobilized around health issues. And you know, like I gave the example, like in Kenya, if a road has potholes, you would easily see communities organizing and planting bananas on those roads and protest, right? Yes. You see that happening. You knock about a border guy and you see the mass coming, the banned buses, the banned vehicles. Like you knock about a border guy, you just run to the nearest police station because there's going to be immediate action. There's no qualified attendant. They'll be shifted between facilities, and I'm talking about a true case in Homa Bay some years back. 7 hours down the line, one hospital doesn't have a blood, that one does not have this, so she's in between and she dies. And we go and bury her without anybody making any noise. These are 2 deaths, one knocked down by a car, one died because of human negligence. Because we pay tax, these hospitals should have facilities, should have tools, they don't have, yet we don't see that as a problem. So it's a depoliticized sector that makes it very difficult to hold those who are supposed to be accountable. That's why they have this leeway to do all those shenanigans they do, because they know there's no political cost to not deliver in that sector. And that's where the civil society comes in. We really need to mobilize and close ranks. So one thing, and you mentioned the Africa Climate Summit week, everybody went home crying, like we didn't get what we want. Yes. We didn't get what we want. All of us were siloed thematic focuses. What if we all consolidated our efforts and said these are all interconnected? Because if there's a climate change is affecting agriculture, agriculture is affecting nutrition, nutrition is affecting health. Why are these two people talking differently? Fossil fuels is creating dirty air. Dirty air is creating health challenges. Why are we not talking together? Yet everybody pursued their issues in siloed pockets, and all of us lost. So that's what we keep doing, and that's what we need to do differently. Now, going to the question of, and let me just say, so one of the things we are doing practically as Pandemic Action Network, and now evolving out of Pandemic Action Network, I have the privilege of being the founding executive director of Resilience Action Network, really putting aside the silos and trying to get people to really look at the resilience agenda. All these interconnected issues we keep talking about are all interconnected, and there's a way we can get monies from all these MDBs, multinational development banks, to do what we call what is it called? Like retributive financing to help bridge for the challenges that they've created. And I think we will have a better run if we can close ranks and work across different themes. And that's what we are trying to do. And we are launching this in Zambia along the Conference on Public Health in Africa next this coming month on 29th. In terms of what I see in the next years for pandemic preparedness and response, I think we are now on the other side of things. So I said we are struggling between different forces, panic and neglect. We are now on the neglect phase again. And we are struggling to make sure we don't relapse back into that neglect. And we have to learn from COVID, because evidence is showing us that we have high likelihood of pandemics, of another pandemic of COVID proportion in the next 10 years, if not less. Like every year there's a likelihood of more than 2% chance of another pandemic, and it keeps on increasing. And this is being aggravated by climate change. Climate change is and human activities are creating conditions that are enabling what we call zoonotic spillovers. Most of the pandemics we've dealt with are of zoonotic origin, if you have not known, that is the case. From this, and you can see from the name, swine flu, bird flu, they're all from those animal origins. Even HIV is of animal origin. So, and these are things that occur because we are now getting closer into the animal ecosystem, our food system. The increasing heat is creating what is something called thermal performance curves that is making animals, pathogens, to have certain traits that can jump now, can make them more efficient in jumping from one species to another. And you're now seeing, for example, US having malaria and dengue fever, for instance, and Europe. So we are likely to have this in the coming days. So what is incumbent upon us is that we cannot wait for another pandemic to occur and then we start doing things. So there are a lot of things that need to happen. Preparedness agenda is something we must keep very high in the political agenda. It will not happen by chance, because our governments are under pressure to do the usual things, build roads and cheaters with other things. So we have to push them to keep this high in the political agenda. The media, the civil society. There are very many initiatives. One of them was spoken about in the morning. So there's a global normative framework reforms, the IHR reform, and the INB process, which is developing the pandemic treaty. Africa needs to make its voice known there. That for us, what really challenged us is equity. How is this proposed protocol, accord, going to address the equity challenge? Other countries have made their position known. If you bring IP, waivers provision, we are not going to sign this. What is Africa's position in that space? We need to be very clear in terms of what is a deal breaker and a deal maker for us in those. And we have to make sure we invest in the right places. Studies have now shown the virus families that can cause pandemics have been identified. Like about 10 families of viruses. And you can plan around this. There's an ambition to have something called a 100-day mission. 100-day mission is based on the science that if you're able to innovate and deploy countermeasures within 100 days, you're able to roll back a potential pandemic, keep it an outbreak localized and dealt with. Africa needs to make sure that it's part of these conversations. They originate the list of priority pathogens, and Ebola is number one, by the way, in Africa. And Ebola is one virus that does not have a vaccine. The Zaire version had a vaccine. The one that ravaged Uganda was the Sudan one, does not have a vaccine. And it's one of the longest viruses in Africa. Because it was only in Africa, it never attracted attention. And a lot of other diseases that are endemic to Africa, like Lassa fever, whatever, all those have never attracted attention. So Africa needs to lead, and we have to drive that agenda to prioritize issues that are important to us. Thank you.
Great, thank you very much, gentlemen. I don't know if you have a minute for one question only. Anyone with a burning question? We'll take just one. Oh, there's a question over there. There's no lady. Oh, there's a lady. Start with the lady here.
That is gender bias.
Finally.
Thank you, moderator, for pushing for me. Hello, everybody. Thank you to the panel. It's been very interactive and very informative. So I'm looking at the shrinking civic space, which is really evident in some countries for advocacy, for civil society. In cases where most of the policymakers are faced with hard questions, they tend to close off windows of engagement. And I think for Uganda, we know that with the anti-homo, I don't want to go there, but that space has really narrowed down. I'll give another example. When you also look at the conversations that are ongoing at global level, I would think that as civil society, we also need to scan the environment. There was a campaign early this year that civil society in Uganda participated in, the anti-farmer grade campaign, and we looked at big farmers, okay? And sometimes as civil society, you can't buy it a hand that feeds you. So some civil society groups could not sign on to certain petitions because they're actually receiving support from these big farmers. So they have mastered the art. They know that civil society, we make noise, like we said, but we stay relevant. So as we amplify our voices, they know who is talking what, and they target you with certain incentives. And that is how we are shut down certain times. So I just needed the panel to just provide overall guidance. How do we scan carefully the environment, and how do we stay relevant, but also make sure that we are making effective engagements at national, regional, and global level. Then secondly, I've had this question since morning, and if you allow me, I'm relating to the TRIPS discussion, the TRIPS flexibilities relating to the public health concerns. We have been pushing for an extension of the waiver to also benefit diagnostics and therapeutics, isn't it? But even for the vaccines that was granted for the 5 years, I would say it's only South Africa that has ably utilized these flexibilities. So as civil society, because as Uganda, we normally engage the country delegates that are going to represent us on these negotiating tables. The WTO is on next year, around, is it March or May? February, yes. Are we still going to push for more waivers? Because then we are not even utilizing the existing ones. My question to us as a region, is it possible to put up strategies that actually operationalize or put into action some of these brilliant ideas that we push for at regional and global level? Because it's one thing to push for an agenda, and it's one thing to actually actualize it at regional and also national level, and possibly regional level. Thank you.
Thank you. Who would like to take that just in very briefly? Would you like to respond? Very briefly.
All right. That's a very good comment, and also zeroing on the question. So I think something that I already mentioned earlier is the issue of conflicts of interest. I think as we work in the civil society space, and like it has already been mentioned, sometimes we have to sit down on the round table with the very people that we're trying to argue against, so that we're trying to make proposals. But it's important to declare conflicts of interest. So that's very important, so that anyone who's listening or who's watching knows where biases lie, and your views and comments can be regarded with that background information. And then on the sort of shrinking civil society space, and how sometimes, big pharma, I'm drawing the example, big pharma sometimes will identify the noisiest civil society organizations and offer grants or whatever incentives that may be. Sometimes they'll be very innocent. There'll be, non-discretionary funding for operationalizing your whatever. And it doesn't have any, restrictions. So unrestricted funding to allow you to work for maybe 5 years. But by accepting that funding, you basically muzzle yourself. So one of the things that we think has potential to create some kind of a workaround for some of these concerns, because they are real, is to also widen the space of civil society collaborations. Like it has already been mentioned, if you're the only person who's seeing a problem, then you're probably the problem. So if you collaborate with enough civil society organizations, even your biased voice becomes diluted in the wider group. So I think as a workaround for that, the best advice I can give, which has worked, is expand your collaboration with other civil society organizations in the space, so that you reduce the impact of your bias if it arises.
Just to add on that, the power of movements, working in movements, working in networks, I think it is the direction we need to take as civil society, because working in silos at the end of the day does not help us. When each and every entity, because you have resources, you want to push your own agenda. Because like you've said, we usually have some resistance from our governments, but when you're working in movements, in networks, it is usually much easier for our issues to be tabled. But also we need to look back into ourselves to strengthen and enhance our capacities to be able to engage in these technical and policy spaces, so that we have our influence impactful.
Right, so I guess this is the closing remark, right? Yeah, so I think...
In a minute,
yeah.
Yes.
Yeah, so, and good for that, thank you for that reminder. So I think the whole point that I can leave colleagues with here, in the spirit of being politically impactful, we really have to create an ecosystem that makes an issue not to be ignorable, that cannot be ignored. And we have to work across the whole spectrum of stakeholders, with the civil society organization informing the media on the narratives that need to go out there. Do not take things at the surface value. There's no policy which is innocent. And you heard the KMPDU Secretary General saying that. Whenever you see something coming out, like what is in it for these people who are pushing for it? It's never for public interest unless public really drove it. And we can always make these things work for the public by asking the right questions in the right order at the right time. Thank you.
Before you put the mic down, you mentioned earlier something about why everyone did not get anything at the Africa Climate Summit, and that's because nobody was talking to each other, everyone was doing their own thing.
Yeah.
So now we are going into COP28. Are you talking to the other civil society groups in the climate space?
Sadly. Okay, so I think there's some effort. It's being seeded. But sadly, not enough. I think the health, you remember the Kanu days of youth winger, women wing. So women were very happy on the wings. You're on the wing. So I think there's a health day that they held at COP. And there are other people being managed in different corners. We're being managed in different corners. So I think we're just being hanged differently. We either hang together or we be hanged separately.
Thank you very much, gentlemen. I'd like to invite you to take your seat. Thank you. Thank you so much. So we are going into the very last panel. Maybe I could give you a minute to just get up and stretch before we proceed.
Yeah, you could stand up and stretch for a bit. So that we can then get into our next panel. Then we'll have our coffee after. Since the feelings were just from lunch, I don't think you're more experts in health about our metabolism. I don't know how fast it is, but there's water on your tables and some some sweets. But then again, some of you guys would say it's not healthy, but dilute it in the water. So I want you guys to do this with me. When I say yak, you touch your head. Yak. Yak, yak is your shoulders, okay? Then yik is your knees. So yak, 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 yik. Yak, 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 yik. Yak. What are you following? What I'm doing, what I'm saying. Follow what I say. Sawa. Yak, 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 yik. Yak, 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 yik. Yak. Yak, yak, yik. Yak, 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 yak. Mwinzi, are you confusing your head and your shoulders? So they're very close. So yak, 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 yik. Yak, 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 yak. Are you sure? Okay, yak, yak, yik, yak, 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 yik. You guys are quite clever. One more round. Yak, 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 yik. Yak, 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 yik. Yak. I'm seeing the cameramen are also meant to be participating. They're feeling they're very busy. They're trying to run away. All right, you may have your seats. We'll have another activity by the time we close. Zainab, back to you.
Thank you. So now we get to talk about the media. You know, the media, we are not used to being on the other side of the camera. We like to be the ones holding the mic and asking the questions. So this time you get to ask the media the questions on how we can better hold the political leadership to account when it comes to pandemic preparedness and response in Africa. And for this section of the discussion, I'd like to invite my fellow journalists up here. Solomon Serwanja, please come on up. Kemisola Abawe, Director Programs Nigeria Health Watch. Karibu Sana. Ibukun, Project Manager, Program Manager Prevent Epidemics Nigeria. Welcome. Oh my God, you look so lovely, both of you. You look so lovely. And I think we need one more seat up here for my boss, Bernard Mwinzi. He asked me to be nice to him. Since you're the host, he asked me to be nice to him. Again, gentlemen, finally you have one lovely lady, so you can keep your eyes on the ladies up here. You can keep your eyes on the ladies. We'll add some color to your life and to this conversation. So I'd like to start with Mwinzi there. How to hold the political leadership to account when it comes to pandemic preparedness. The National Media Group has pioneered health journalism in this region. Do you think we're sufficiently holding the leadership to account?
It's never sufficient. Obviously, it's never sufficient, but at least we are trying. We are doing something that we were not doing before we started doing health reporting. And that's because we are learning on the go, really. Governments have been in existence for years and years, for eons, really. So they have perfected the matter of how to deal with publics. You know, they know how to engage with them. They know how to sell policies or to lie about the policies that they are selling. But the media, the intersection between policy and government and the communities themselves is sort of learning on the go. That's why I'm saying, yes, we are trying. We are trying to make sure that governments are accountable to the people, you keep the premises that they give the people. But are we doing it enough? I wouldn't say we are there yet, because that would be patting ourselves on the back too early. The fact remains that publics look up to us to tell them what's happening. They look up to us to interpret issues, to analyze government policy, to reveal what governments are doing right and what governments are not doing right. And therefore, for us, this is not something that we'll say probably the next 1 month or in the next 1 year or in the next 5 years will be done with. It's a continuous struggle that we must keep fighting.
Thank you. I think you'll be sharing a mic with Bukun. We seem to not have enough microphones unless there's another one. But before another one comes, you'll share with Mwinzi. So picking up from what Mwinzi said, it's a continuous learning process, and we still are not doing enough. What do you think are the challenges that the media faces when trying to communicate the progress in the pandemic preparedness?
Yeah, first of all, thank you for privilege of speaking on this panel. My name is Ibukun Guntala. I'm a program manager at Nigeria Health Watch, implementing the Prevent Epidemics project in Nigeria. And basically this project, the aim of this project is to build and demonstrate policy and increase public and policymaker awareness around the importance of epidemic preparedness funding, but particularly for Nigeria at both national and subnational levels. So thank you for that question. Around the challenges that the media faces in holding government into account, I think on some level, I would like to relate it to the African region, because I know even though we have very different contexts, we also have very similar challenges in terms of the media holding the government to account. I think first of all, it starts from a place of health not being a topical news, right? So you barely see health news making the front pages, right? And even when health makes the front pages, you tend to see a lot of, I would say maybe not so much accurate reporting, more of like sensationalism in a bit, which obviously does not do any good, right? So I think on some level, the first step is also in terms of like the capacity of the media, particularly when it relates to health issues, because I know a lot of people in the media space sometimes do not relate smoothly with health-related issues. So there always seems to be that gap between understanding of the health issues, and that always reflects in the kind of reports they make, and also obviously influences the ways that we can inform the public and also then build accountability for the government. I would also say that another level in which another challenge that the media experiences, it's that connection or that accessibility to even relevant resources and relevant expert matters, like subject matter experts, so like I would say. So one key thing that we did a lot in Nigeria under the Prevent Epidemics project was to create those opportunities for interaction. So for example, there's a public health legislation called the Public Health Emergency Bill that was recently developed. And for a lot of people, there was no awareness around the bill, because the purpose of the bill was to repeal a 90-something-year-old public health legislation that we have in existence in Nigeria. And there was just not that connection for the media into those issues. So what we tried to do was create avenues for opportunities for the media themselves to engage with federal legislators, in this case, who were responsible for drafting the bills and who had been pushing the advocacy for the repealing of the Quarantine Act. And we through that, we help them, first of all, increase their knowledge around these critical health issues, but also then allow them have that opportunity to pass across the message to the community members, who can then, obviously hold their political representatives to account. So I think let me just stop here.
So Bukun, I'd like to talk about storytelling. He mentioned that when you see health stories on front pages, sometimes they're riddled with inaccuracies or sensationalism. Pandemics is a very boring story to tell. Very boring. No one wants to be told about pandemics. And in fact, when COVID came in Kenya, the government used a lot of fear tactics, telling us how we are going to kill our parents. You're taking the virus to your parents. You're going to kill your parents. So how can storytelling make it easier to tell the stories about pandemics and get the audiences more engaged and interested in the subjects?
Thank you so much for that question. First off, I will say thank you for this opportunity. And just being here, I've learned a lot about what's happening in other countries. And I think that fora, not sure what word is right now, like this are useful to drive these conversations and also catalyze cross-learning between countries. So thank you. We do not take it for granted. Now, to answer your question about storytelling, someone on the first panel mentioned Vuari Diaso, who was a young medical doctor who fell through the elevator shaft in a Lagos hospital in Nigeria. And while I was sitting there earlier, just listening and absorbing some of the conversations and what people were saying, I realized that that story was sensationalized without doing the kind of reporting that would have caused significant change. So after everyone had said, why did Vuari have to die? The hospital was negligent. The elevator had been faulty for a really long time, and nothing was done about it, in spite of the fact that the medical doctors had complained multiple times to the authorities, but nothing was done about it until someone died. And everyone reported about it. Twitter was ablaze, it trended. Well, I, for one, for Nigeria Health Watch, we wrote a story about it, by the way, so we had it on our website. One of the things we would do is go back and do a proper investigation. First off, why did that happen? Off the top of your head, you would say corruption. You would say the leaders were not accountable. No one held them to account. But there are probably some other nuances in the processes that you could have investigated and brought something out of that would have led to significant change. And I told that story because your question was around storytelling. How do you take people's lived experiences and bring that to platforms that policymakers, decision makers, legislators will see and have to do something about? So it's two-pronged. One is you leverage media to reach policymakers, to reach legislators. But you also leverage media to inform the public, to build public support. That's what advocacy is, right? Building public support, galvanizing support, increasing the volume of voices. Someone in the previous panel talked about mobilizing a lot more people. When a lot more people are talking about something, then you have increased political capital that can cause change. So, direct answer to your question. Tell human angle stories. Tell the stories of the people who are experiencing what you're trying to change, and use platforms to amplify those stories. Make sure that a lot more people see it, and we can actually sensationalize health. We can make it a lot more popular than it is right now. It's boring, yes, a lot of people don't like to talk about health, it would not trend. I'm going to say this, please do not stone me after. Thank God for the COVID-19 pandemic. That got a lot more people talking about health. People were more interested. So yeah, tell human and good stories, I think. That was a roundabout way of answering your question, yes, wasn't it? Yeah.
Yes, Solomon, so tell us a little bit about the experiences you've had telling stories about pandemics.
Thanks a lot. I agree with you entirely. But three things for me come into play here. So any of us who have been in the newsroom know the first question that the editors ask when we are pitching stories to them is, why should I care? The moment you fail to answer that aspect, in fact, I had a very gruesome experience with a South African editor at the BBC, I pitched 20 stories and she rubbished all of them. And she said, Solomon, why should I care? Why should I care? And I think when journalists answer that, this is why you should care about reporting on pandemics. This is why, when you look at the documentary that we aired at first, we used the format of a cold opening. And with the cold opening, in that film, I was trying to take people back to what we went through, reminding them about how we lost loved ones, how we opened mass graves, how we ran to different hospitals and there was no one, how loved ones died in our hands, and yet we could do nothing. It was a cold opening to remind us what we went through, and therefore why we should care, that anything can happen again, and we will go through the same thing. The thing about human beings is that we forget very fast, and that is very typical to Ugandans. We move on very fast. Today we are talking about pandemics. Okay, COVID, we are dying. The next day we are on totally different things. MK projects, Muhoozi Kainerugaba, Bobby Wine, and everything. And we get lost in that. And we forget the very important things. And I think it's the role of the media to, yes, report the politics, but bring the conversation back to critical issues affecting us as a people, as a society, and therefore hold our leaders accountable. You know what I mean? So the first thing for me in my storytelling is I always want to remind people that during the COVID-19 pandemic, none of these ministers, none of the presidents they couldn't fly out. I mean, many of our leaders come to Nairobi Hospital. Hey, anything. Hey, he has been flown to Nairobi International Hospital. Oh, yeah, Aga Khan. Oh, he's in London. Oh, he's in... COVID brought a harsh reality that our leaders could not actually get out. And that was a reminder that if the health systems are not strong enough, it will catch up with you. And so for me, the way I tell my stories and the experience has been like, if you do not fix the healthcare system, it is going to catch up with you. So I always tell it from that central point. That's the first point. The second point is that health is just like medicine. It's complicated. I mean, we're talking about the partnership for vaccine manufacturing. You know, Partnership for Africa's Vaccine Manufacturing. That's crazy. It's a whole document. I don't know how many pages, about what? 100 plus pages. It's too much. And so if you're to get a journalist to read and internalize that, and so most likely we report, oh, the African Union and Africa CDC have launched the Partnership for Africa Vaccine Manufacturing, and we say, during the launch, a soundbite. He also added soundbite. Then you know what we do, guys? Yes. Then we do a small backgrounding. COVID-19, so WHO said that we lost 6.9 million people. Solomon Serwanja, NTV Tonight. And we are done. But in that big report, there's so many things, literally, right from research and development to infrastructure development to fill and finish to investment into the workforce. Everything is in there. But you see, and this is where I find that sometimes journalists, we are lazy. We only report the event in many of these reports. We never get deeper to actually say, hey, editor, can I get off the desk to actually internalize this and go deeper and bring it home and put some face to it and get deeper? And for example, say this week I'm doing a series on vaccine manufacturing in Africa. And today I'm doing research and development, go deeper. And this is why you should care. Then the next day I go into infrastructure development. Then the next day I go into all these things, technology transfer, and examine all these things and be on a health desk, but I'm still using the information. So most of the times we repeat events and not really the core bit of it and getting into deep conversations. My last one is on the nomenclature. Our audiences are not medical people. You know, so guys when you get into this guy's world, they're talking about molecular biology. They're taking you deep into the deep science of it all. And you're listening to all these things and you're like, God, I'm not a doctor or a pharmacist or what. But it's your job to actually chew all that and then serve it to the public, which is a baby, into the little finest forms that they can take it in so that they can answer the question why we should care. Thank you.
Or you have something to say about that?
Yeah, well, not about that. I think he completely said everything there is to say about that. Same thing we experience in Nigeria. Lots of capacity issues, which I think Ibuku already spoke to. But I wanted to add something to the question around storytelling. And it's that a lot of times we focus so much on what's not working. We report on the problems and the issues that we have on the continent. Whereas there are pockets of spaces where there are solutions being implemented. There are some things, for example, that regional bodies are doing, that countries are doing. We had quite a bit today about what Kenya, Uganda is doing to bridge the PPPL gaps within their countries. And I think that those stories need to be told a whole lot more. The official term for it in most spaces is solutions journalism or constructive journalism. And it's gaining ground because it's proven to be an effective tool for advocacy. So when you show your policymakers and your government what works, then you can ask them why they aren't doing something similar. And this is something I think needs to be done across countries. So there are things that Nigeria, for example, has to learn from Kenya, from Uganda, and the other way around. I just found out today, for example, that you don't have a national health insurance fund, that you're working towards that. Whereas Rwanda has over 90% insurance coverage. How do you tell these success stories and catalyze learnings between countries to help build the PPPR advocacy space?
Munzi, picking up on that, how to tell these success stories. COVID presented an excellent opportunity for African media to collaborate and tell these stories as a unit, and so that you have richer stories from different parts of Africa. Yet we didn't see that happening. Why was that, and how can we work towards working together more as a continent so that you can richly tell the African stories?
I think the first thing that COVID taught us was that diseases are not respecters of boundaries. Yes, we could not travel across boundaries, but the virus was traveling across boundaries, and that was something that we in the media had to grapple with to understand what's happening. I remember us sitting in the newsroom first, as the medical fraternity was, struggling with understanding what this virus is, what to call it. I remember in the newsroom we were calling the disease SARS-CoV-2, and I'm like, why are we calling it this? So even before we're talking about the nomenclature and all that, even before we actually decided what to call this thing, it was spreading in our communities. And storytelling for us has to be something that is deliberate. Sawaji is talking about telling the story in ways that people can understand. People know that there is a virus, but can we really, really bring that virus to them in such a way that they understand what this thing means? We're talking about social distancing, and what is social distancing to somebody who lives in a slum? What does it mean to them? When we talk about all these other things that the medical fraternity was throwing at us, we in the media were also actually lost in the sea. We were learning, as I keep saying, on the go. But to your question about whether media institutions across the continent could collaborate, I think the first thing that crosses my mind is, why do we exist in the first place? Why do media exist? The panel that I just stepped on talked about, we are the civil society, saying we exist in the interest of public and for public interest to advance the interests of the public. But what are the interests of public when it comes to health reporting, or specifically in this case, when it comes to the pandemic? The practice in newsrooms has always been that this is my story, this is my exclusive, I'm going to hold it, right?
Your editor will not even know until
Your editor will not know what you're working on until it's ready, then you serve it hot. And you say, you cannot run away from this one. But we at the Nation Media Group were a bit lucky in the sense that we have presence here in Nairobi, we have presence in Kampala, we have presence in Dar es Salaam, and we have presence in Kigali. And therefore, it was very, very easy for us to call, our colleagues across the borders and ask them, what's going on there? What have you seen? Have you seen, are the guys in Dar es Salaam hiding the deaths? We actually suspected they were hiding the deaths, and actually even sent someone from here because we suspected that our colleagues in Dar es Salaam were also hiding the deaths. But what we realized in the long run was that when we work together, and this is, to answer your question, when we work together, when we pull together, the story is better. It's actually better. It was, COVID taught us that we can actually do cross-border story collaborations. And so you would see a story that has 6, 7 from across the continent. And therefore, we have been doing such collaborations with our colleagues across the border. What you'll find, though, is that it is still a Nation Media Group initiative. So I have not reached out to her or to him or to other people who are not part of the family to ask them, how can we work together to tell this story? Now, collaborations for me in the current media environment are very, very important. As you understand, media revenues are shrinking. We are facing a lot of commercial pressures as a result. We do no longer have the budgets that we used to send a reporter to Nigeria, for instance, or to all these other places to do these stories. But if I have you in Lagos, Johannesburg, or Luanda, and I can place a call to you and I tell you, I just need 9 paragraphs or 5 paragraphs from you. What are you doing with this health bill? What are your concerns? What are the lived experiences of the patients in these places? Then it becomes easy for us. Finally, before I talk too long, one thing that we African journalists must realize is the African story must be told by us. It must be told for us. I know we have a lot of wire services operating on the continent, but the African story, for me, has to have African boots, African journalism boots on the ground. Why? Because we understand the cultural underpinnings that make people make the decisions that they make. Whether it's, I am going to live the way I live, I have malaria, and so I am going to just walk to a chemist shop and ask for fancy or whatever it is. We understand why communities behave the way they do, why people behave they do. And there are issues there that only journalists who are willing to go there to interview people, to live with them. I normally call them anthropological studies, actually, because sometimes that's what journalism is. To live with them, to experience their desires, their fears, their commotions, then becomes easy for them to tell a complete story. And until we have those African boots on the ground, that story is not complete.
Okay, interesting thoughts there. Ibukun, looking at, going back again to the COVID pandemic, for many media houses across the continent, there were these accusations of being a government mouthpiece, that you're just repeating what the government is saying, or because the government said you're going to die, so you're telling us you're going to die. COVID does not even exist. So those are some element of public trust missing. How do we fix this going forward, taking the lessons from COVID pandemic and for future pandemics? How do we ensure that we are seen as media and not government mouthpieces?
Okay, thank you so much for that question. Yeah, there are some, I would say, trust issues, right, in different countries. And some of that is based off of, obviously, previous experience, natural distrust that some community members have for the government, and you just feel, okay, you're just using media as a tool to feed us a narrative, you understand? But I feel like us as media, we need to always, we need to go the extra mile. Like, so I bring up an example of when it comes to translating evidence into, properly digestible information for community members. A lot of media people just, like you said, just relates events and just relate these numbers, but they don't go into actual dissection of the actual issues you get. So there's also that responsibility that media has around, actually trying to understand evidence and actually translating that evidence and presenting that evidence as it is to committee members, whether it favors a certain government or not, right? And you know, there are obviously all, okay, let me give you an example now. I think personally for me, a personal moment of realization where I actually saw the media as what they are, as what they need to be, was the Ebola outbreak. This was way back in 2014. Now, I'm taking us way back right now. And, you know, there was a lot of, I would say, misinformation. There were stories around how you need to bathe with salt to prevent you from contracting Ebola. And obviously it led to some deaths, by the way. It led to some deaths through that. And really, it goes to just show how much the media needs to go into actually translating evidence. First of all, getting the evidence, right? And then secondly, understanding the evidence, breaking it down into simple, understandable language, right? For community members to be able to digest. And, you know, just maybe taking a step back from being looked as just government mouthpieces. Although I'm not particularly saying that government information that comes from government agencies is wrong or it's political in nature, right? But sometimes we as media have a responsibility to further dissect some of these things and make sure we present accurate information based on evidence.
Okay, Kemi, journalists, advocates, activists, is there a difference?
You know, it's funny you're asking me this question because in the journalism space in Nigeria, Nigeria Health Watch is actually not fully a media organization. So we're not journalists. I'm not a journalist, by the way. My training is in medicine and surgery. But I have found myself in this space. And I remember I was at a meeting once, and one of the veteran journalists in Nigeria was telling me how Nigeria Health Watch is, you're not exactly media. But we find ourselves in the middle between journalists, advocates, activists, CSOs. We're actually a CSO, technically. We're a not-for-profit communications and advocacy organization. So when you ask if there's a difference, I would say if I were to put the hat of a journalist on right now and be a complete purist, I would say absolutely yes. Journalists do not like to be termed as activists or advocates. It's completely different. What we're trying to do is pass the right information across, empower the public, and foster trust, right? And just inform the public, essentially. But I do think that there is a need for these three different kinds of people you've mentioned to work more closely together. In our experience in Nigeria, for example, and also in the region, I think, we were at an African CSO workshop earlier in the year. And a lot of CSOs do not like to work closely with media, with journalists, also governments, because they don't want to be misquoted. They don't want for something they said to be used against them. They don't want what they said to be sensationalized. And then typically when, for example, a government officer comes and talks about his 4-point agenda with a lot of details and talks about what he wants to do, usually media will just take one thing that is sensationalizable and just use that and run that. So there are a lot of dichotomies between the three, but I'm finding that media advocacy is complementary, and that these three people, whether you're an activist or an advocate or a journalist, can work a lot more closely together to push the PPPR agenda on the... Oh, a purist journalist is about to respond. To push the PPPR agenda on the continent.
He's about to interrupt you.
And I think that there are ways that this can happen. For one, clear example, civil society organizations need to leverage media to push their advocacy objectives. You need to be able to put your advocacy objective in the face of people and get a lot more people talking about it. You need your journalists. You need media platforms to do that. You need to use social media, use traditional media, radio, TV. But the journalists lack capacity to really dissect. I mean, we've talked about that already on this panel. I don't need to talk about it more. To really dissect these issues and accurately report them in a way that it affects change. So why would a journalist and an advocate or a CSO person not work more closely together? And this is something I think we need to facilitate a lot more of.
Yeah, you're right. I wanted to interrupt. As a result of the mistrust that you're talking about, interactions between government and media and the science community here and the media tends to be very transactional. The researchers do not trust us with their time, with their interviews, because they say, as you say, you're going to misquote me. But there's a problem here. The best way for any information to go out there is through the media. And it is through professional media. I know nowadays we're talking about social media and all these other things, but our role in this health conversation, to me, is very, very simple. We operate in the BCC. You know, when you have these branches, as far as health communication is concerned, we tell people, wash your hands, whether it's or through our editorial, wash your hands. Why do you say that? If you do not do this, this is what is going to happen to you. Take your drugs, take them well. Take yourself, watch your weight. It's basically BCC, behavior change communication. But we are not interested in these around you and how you're going to affect them and all that. Change for us in the media happens at the personal space. If I write one story and it impacts the life of only one person positively, I am a happy person. I go home. Let it be a top-down approach as far as change is concerned. For us, I don't want to use that because it has political connotation, but it has that bottom-up approach to change. It is, let me change this person, then this person changes the family, the community, you know, the educators. And we cannot educate if we do not have the material. We have the audience, but if we do not have the material, then we can't. To be supporters, we support your health movements, the things that government is working on. We say we must collaborate efforts, whether these efforts are by the national government, the county governments, or by health professionals. There is no way the media can succeed in this endeavor or in the research, space and all that. I realize that they have this treasure trove of information about things that they are doing in their communities, might misquote us. This study is still something that is still in the works, it's not ready, and therefore it should not be published yet. But what's served better? And as I keep saying, you and I exist for the interest of the public.
Great. Solomon, I'd like to give you the last word, and you can talk to our investigative piece during the pandemic, and it got our journalists in trouble to the point that the second part of that investigation never made it on air because the forces that be fight back. So how can journalists uncover the rot within the system if they're not safe?
Thank you very much. So let me first of all talk about investigative journalism during pandemics. I think that during pandemics, accountability is sacrificed at the altar of saving lives, right? You can't question how money was spent because we are trying to save lives. You guys remember supplementary budgets were passed. No one is questioning anything. Every time you'd ask the Ministry of Health, they're saying right now our mandate is to save lives, They kept information to their chest. They would only give you what they would love you to hear at the time. And until when the dust started to settle, that's when the COVID billionaires came. We did a project of COVID-19 and the money in Uganda. I remember there was a nurse doing some really good work. John Allen also picked it up. West African, David, I think also. There are a number of investigations that then started to come out of the pandemic. And so I think that investigative journalism plays a very critical role in following the money in pandemics. And I think we need to take the lessons that we learned during the pandemic to actually prepare better. Because if you look at the Auditor General's reports that were released, again, we do the usual things. The Auditor General has submitted this report to the Speaker. The Speaker then is going to send it to the Committee of Parliament, the Parliamentary Accounts Committee, to investigate, which is going to be next year and the other year. You know how we all go through it. But inside the Auditor General's report lies a lot of information, at least a sneak peek of what is really happening. I know that different countries launched investigations into COVID-19 expenditure. I know, for example, in Uganda, that there's a parliamentary committee on COVID-19 that went really to different districts to follow the money, and what they found was really nasty. But what we do? We just said, oh, the committee has finalized the report and ABCDE, and that's all, right? But inside that cache of documents are like evidence, pieces of evidence that can be used to actually reopen, you know, the healing wounds of COVID, if you want to say that, and, you know, bring up some of these things that happened. I can guarantee you that many people who stole money during the COVID-19 have never been arrested, have since moved on. Life has moved on. Who wants to open the books? I don't know. But I think it's the role of the media to go back and reopen those books of accounts based on evidence that has been presented by the Auditor General and by these different inquiries. I mean, many of us know, for example, that there was different monies that were given to install maybe oxygen plants or even to buy equipment. I mean, we all know, if you go back to the monies that were allocated to different sectors to do work, go back and look at those monies and what they did and whether what they did still stands, and you'll be surprised. Some of it may stand, but some of it may not stand. So I think that investigative journalism plays a very, very central role in pushing for accountability, especially during the pandemics. Let me just come and hit on your question a little bit about safety. Many of you know that when you do an investigation, you're in trouble. I know, for example, that John Allen and Moha had to actually, when they were still doing some investigation, like as a group, they had to sometimes take leave in, you know, outside countries. I mean, we do the risk assessment before we do these investigations, look at the level of risk that could come with it, and look for plan A, plan B, plan C. I've been arrested, I've been there. I have paid the price sometimes. So sometimes I do an investigation, and then, you know, I take a deep dive, I submarine a bit, get off the planet, and keep quiet a bit, and then come out, and then do another one and submarine. At least I do 2 investigations a year. Yeah, so safety is very important. Unfortunately, in many of our newsrooms, you're as good as your next story. So you do this investigation like, oh, editor, you're back in the newsroom, and they allocate you to the next story. And like, do you even care that, you know, someone is following me? Or, you know, at the time I did an investigation and I asked my editor, can you fly me at least to Nairobi? At least to Nairobi, to just get away from this storm. And I remember what he said, no, I'll get your counterterrorism police to protect you. I'm like, okay, does this add up really? So safety of investigative journalists remain very, very core, especially when you're investigating corruption. You remember what happened to the COVID billionaires. I know that there is the invisible hand of the executive that infiltrates our editorial policies to stop some investigations from running. A call just comes and, you know, the editor says, everything is, yes, we've crossed everything, we've dotted the I's and crossed the T's, and the story has all the evidence. And then the call comes from the top floor. Hello, you know that one, we cannot really risk. Okay, you see the condition we are in economically, it will bring us problems. I know these things are happening in our newsrooms, and the next day, the story is not on air, or the story is not published, and you come back the next day and ask your editor, and your editor says, you did a good job, we're trying to review as the editorial team, everything, so, and then the story, the journalists in this room are laughing because it really happens. Then they say, no, we'll publish next week, hang in there. We're just trying to, you know, they don't want to discourage you because you put in all the effort, but they also have pressures internally to deal with. So I think that it calls for editors that are going to stand by their reporters, and editors that are going to stand by the principles of the newsrooms and the editorial policy to defend journalism, especially investigative journalism, during pandemics.
Thank you very much. That's an excellent point to end this conversation at. I believe now it's time for tea, unless Dan will allow us time for a question too. Oh, there are a lot of questions. Journalists don't like being asked questions.
Yeah, when it's our turn, everyone wants to talk. You guys want a bloodbath. So This one looks like there's a lot of interest. So I'll come here and I'll also, there's a government guy there who wants to ask a question. We are ready. Let's start.
Thank you so much. I'll be very brief. Yeah, my name is Jack Ndego. I work with an organization called Kanko. I'm based here in Kenya. Well, a wonderful discussion. I just imagine during the COVID-19, during the, what were we calling it? We had to stay at home. What we were depending much of the information, whether we're going to have another lockdown. We were basically staying there glued to the media, listening to what is going to happen next. So much of what was happening and the information and the quarantine or whatever, we were mostly depending on the media. So that speaks a lot about the role of the media. But then I just want to ask a very interesting question, a crazy question, because I work in the civil sector, I work in the media on many areas, and even some, on some issues whereby you say, I don't want to be quoted, but this is the information. Or even go further and give them the exact story, the information, and you tell them who even to go to, talk to the ministry, but also giving a rider that they may not even talk to you, but this is the story. Sometimes published and not published. But if I was to ask this, what would the media need out of what we learned from COVID-19? What would the media need if we are to have the next pandemic? And I started because I stayed at home. Most of us were staying at home. It was very clear. But then along the way, by the virtue that we were learning that from the media that, again, COVID is not killing so much of Africans, because I'm watching CNN, I'm watching NTV and all that. Then the time took for the vaccines to come. So by the time we are having the vaccine, then we realize the deaths in our context are not too much. But we're also learning from the same media. Could it have been what Amref was presenting in the morning be the reason for that? That, wow, still the same media I'm learning that, hey, we're not dying as Brazil, I could see US and all that. Then I'm like, possibly I'm not so much at risk. But I'm not saying that because I'm fully vaccinated. But that's the question. How would the media learn from those lessons in the next pandemic? Thank you.
Thank you.
Thank you very much. I'm a government official, and so some of these questions have come to us, especially in terms of financing. You know, once you put out something, we've carried our credibility to the line. Do you ever go back to make corrections of very wonderful stories you make, and you find there were errors that need to come back to exonerate some of the officials?
Thank you. Then I'll take you, then we'll come to the back there.
Okay, thank you so much. I think you are not just there to receive questions from our end. You also deserve some compliments. Yes. Now, my name is Gabriel Muswadi. I'm a public health specialist. And I've been following the work of NTV for quite some time, since around the year 2000. And I know that NTV was quite involved in something called science reporting on biotechnology, when we had a lot of misconceptions on GMO. Why don't we have that issue coming up so that we don't get concerned about misreporting on molecular biology findings, on genetics, and on epidemiology? Two, I would also like to laud NTV for once. The Kenyan media space has always been dominated by, do you have lawyers here? Forgive me for that. Lawyers, and the law is very clear. Every morning, we're always used to, the law is very clear on this. But when there was COVID pandemic, at least we had molecular biologists invited to discuss the molecular basis of pandemic. We had epidemiologists discussing the epidemiological basis of the pandemic. And we had scientists discussing that. Unfortunately, again, the lawyers are coming back. Can we make sure that we sustain the effort of health science discussion in our media houses? Thank you so much.
Thank you very much. I will come to these questions. Allow us to pick these, have these ones responded to. And as I want to pull a bit of a first one. Our editor-in-chief at the Nation Media Group is among us, Joe Ageo. I'll invite him to speak briefly, because I know he may need to leave sooner than we end. He may, at his discretion, choose to address some of the questions that have been raised. He should. Those who are under him are saying he should. Let him take the bullets for us. So I'll invite Joe, and he will speak briefly to us, so that in the event that we run a bit over when he's available, we will not have tied him down. So Joe, karibu sana. And if you remember, at the time there was a presidential debate, and he was moderating alongside Linus Kaikai, and then Linus was being called Joe. So this is the real Joe. This is the real Joe. No, you could just stand here.
This guy is making me feel like a politician. You know, when politicians stop everything, they come in a helicopter, and whatever you are doing stops, and that's not how it was meant to be. I had told him I would be leaving at some point. I didn't tell him, stop right there. But I'm here now, so it's good to see all of you. I don't know where to start. I'm a journalist, by the way. All of those things that have been said will be answered by these people here, because but really this was just to thank all of you for showing up for this very important conversation. I remember my best recollection of the interaction with our health on this continent. I grew up in the village, and my mother used to do something which, if you grew up in my village, you probably will understand. But anytime we had a cold, she used to get these concoctions. I don't know where she got them from, but then for full effect, she kept them in used snail shells. And then you would get some drips in your nose. I never had the courage to ask why they did that. But when I get those recollections, it brings home some of the conversations that we are having today. So throughout this day, I followed some of the conversations. I missed the best part. Pamela here gave me wrong information about the lunch breaks. I wasn't here for that. But ladies and gentlemen, I think that as a media house, this is a question that we take seriously. We have had some illuminating conversations here, reflecting on the complexities of the healthcare systems in Africa. Because when you talk about pandemic, someone asked me whether I think we are prepared for the next pandemic. And I said, maybe not, but I think we are more prepared than sometimes we give ourselves credit for. And that is just to say that we deal with very many problems in this part of the world. And for that, I think sometimes we don't, even as media, give enough credit to our health professionals who try to do this work under very difficult circumstances. But in so having this conversation, like I said, that as the media, we come in between, because there is scientists on the one end and media, and this ladies and gentlemen up here have so eloquently talked about that. And in my coverage, I think of myself as a science journalist, and my experience has been exactly what I was hearing there, of this huge gulf between the scientists and journalists. And it is really many times about the epistemology of the two professions. You have scientists have a certain way of acquiring knowledge and disseminating it the same, and journalists also have their own way of doing that, and their cycle tends to be a lot shorter. So when you're still there saying, yeah, this is very important information, but there's something that we need to just be very sure about. So the journalist, okay, just tell me, I will be able to say there's something you need to confirm. Say, no. Because again, when you go back to your peers, they'll be asking you, what is that you were saying? Don't you know this thing has not been peer reviewed and all of those things, right? And the journalist on the other side, the editor, is saying, but how can you be waiting for all of this while knowing that our deadline is probably whatever time. Now with digital media, it is now, isn't it? So our objective beyond everything else in bringing such conversations together is to bridge that space, because we recognize that as journalists, we like to see ourselves as step-down transformers. There's this high voltage stuff coming from all of you experts, and then there is the public out there that needs to understand what they need to do with that information. And that makes it extremely critical for us as journalists then to understand what on earth is going on in those spaces. And I think that someone mentioned it, it calls for a greater degree of trust, which is to say, many times people think that journalists just go around looking for something to publish. Sometimes we just want to understand what is going on, so that the next time when we have to publish, we know what to say. And that is because sometimes we have seen a situation where scientists are working on something really big, but they wait for that thing to completely materialize before they say. Supposing I knew there's something you're working on, not because I want to report it, but because I want to follow when I meet you for coffee and say, oh, how is that thing going? So that by the time it is coming, I am prepared, I understand. I tell my friends that we don't know everything as journalists. The things we know are the things we have been told. That today, if there is a fire somewhere, it's not that I have some magic. Probably there is just some guy who lives in some neighborhood who I had tea with last week and say, oh, by the way, there is some fire here. Would you guys be interested? Then I look like I know there's everywhere there's a fire, but it's because it's somebody who told me. And it's the same thing with scientific information, that we don't know until we are told. Being told could be, I've read something, but it works best because you work on those projects and so you know what they are, so you can let us know in good time. Now for us, because there are many discussions that have happened here and I am the least qualified to try and go through them, and I'm sure that Pam is going to do a better job of that in a few minutes. But just to pledge that this is a conversation that we do not intend to end here in this one-day conference. It's a conversation we want to continue through our platforms and also to compile these thoughts into a policy a brief that can inform different conversations that go on, a policy paper that captures all the different aspects that have been here. But for us is to say that we privilege health conversations because we recognize how important that is. And COVID-19, for one, demonstrated to us just how important this is, that it affected everything. People couldn't fly. For us as journalists, there are things we had to shut down because of that. We couldn't call you guys and say, okay, let's sit for an interview. Say, no, just tell me what you want on phone, or we could do Zoom and all of these things. It basically changed everything. For the first time, we saw police officers asking us, where are you going? Not because I didn't have a national ID, but because there was a disease out there somewhere. So it means that we may have not have realized up until that time just how all-encompassing this question of health can actually be. And so just to say that it really has been gratifying to see all these people come together, many of you on short notice, but to see the kind of conversations we've managed to put together, it is really something that is worth taking forward. And that is why for us as an MG, we would like to do that. So without boring you, I typically get paid for talking. So in a situation like this, I control myself. And so I'm going to just say a very big thank you to my colleagues who've helped to put this together, but more significantly to all the delegates who have traveled near and great distances to come to this meeting, and to say that for all the foremost experts, health experts in this room, for the impassioned activists, some of whom we have heard here, to say that our conversation is not ending here. We'll keep looking for you to make sure that the health agenda on this continent is put front and center, and more particularly with regard to the pandemic preparedness and the response thereof, because we know now, more than we have ever known, that this is the one thing that if there's anything that we should all pay attention to, then this is it. So thank you very much for coming. Thank you very much for talking and for listening. And thank you very much for keeping up with my long-winded speech. All right. Thank you very much, ladies and gentlemen.
Thank you, Joe. So we'll just pick it up with the questions that have been thrown this way.
Yes, so the question on what will the media need if we were to have the next pandemic, I'd like to throw that to Mwenzi.
For me, it is very, very simple. We need better flow of information. As you know, the word media itself suggests we practice mediated communication. We need people who will tell us this is what this means. We need better understanding of whatever new pandemic we'll be facing. We need, if I call you and I tell you, I know that, you know, sometimes, and there's a question that I've been posted about what we do when we make mistakes. I know we are not perfect. We do make mistakes sometimes, and health is a matter of life and death. But without you, we cannot tell the health story better, and we definitely cannot tell the pandemic story better. So better collaboration, access. I remember when the pandemic hit, I kept asking the Minister of Health whether they could grant us access to the COVID wards. And the question I was always being asked is, are you sure? Are you serious? Are you suicidal? Even the doctors themselves do not want to go to those wards. But I kept insisting. I said, I want to go to the COVID wards. And eventually, I was the first journalist in the country to hit pictures of what is happening. And sometimes even demystify these things. I remember when I did that story of the first ward rounds in the COVID hospitals, people actually realized that, yes, this thing is dangerous, but it is actually not a death sentence. Because I was talking to people, a woman who had been detained from, she had just flown in from London, tested at JKIA, tested positive. She had been held there for some time. And she was okay. She was okay. So the image that we had in our minds about what this looks like was these guys who are trapped, they have lines running from their noses and so on and so forth. But when you demystify and you tell people, yes, this thing is dangerous, but there are patients who are living with it and they are okay, they are generally fine, then you sort of take the fear out of the communication and tell people, yes, it's serious, but you can live with it. So access is important to us as in the next pandemic.
Solomon, I'd like you to take the question of credibility and correcting errors.
I think this is one of the things that we hate to do in journalism. I'm sure you've seen, in fact, there are so many court cases. We've been taken to court, different media houses have been taken to court, and they have had to pay heavily for some of these mistakes. I know there are media houses that are struggling with court payments. I think one of them is President Museveni, who took the Daily Monitor in Uganda to court for the story that they ran on vaccines. And I think the president was given, the court told the Daily Monitor to pay 300 million. And they paid the price. And we know it as reporters, as editors. And we try to do our job in terms of fact-checking, and especially investigative journalism. By the time an investigative story comes out, it has been fact-checked, triple-checked, and yeah, and we try to close all the leaking bits. But even with all those, you know, different eyes, 4 eyes, 6 eyes, sometimes some things filter through, and they really bring us, they test our credibility. I know that different media houses offer apologies. We apologize, you know, in our story yesterday. We hate to do that, by the way. I need to mention it. It pains, it really hurts for you to issue an apology, and some of you even want it on front page. Apologize to us on front page with the headline. An apology has come out in the newspapers or even on TV. We try to apologize, but I think that we do our gatekeeping quite very, very well. There are a few cases where I think the editors in this room know that it's not really too much. But some of it, when it comes through, we really apologize. So I think it's mature that we take responsibility for our mistakes that we have made.
Thank you. Dan, you want us to continue?
No, just the last round, there were a number of hands, and I don't want to be told the media is gagging. So there were a few at the back here. So, and I'll request we make them very brief in the interest of time, kindly.
Thank you very much. I have had many things that have been said. Take what I'm going to say as a tribute to National Media Group because they deserve it in relation to reporting on COVID. When we first developed the country, there are several media houses, at least two that we approached. They said the Ministry of Health has not allowed them to cover that story. Has it been, the model, has it been checked by the ministry? Another media group said that, we haven't heard of your name before in disease. What's happening? It took the National Media Group to report on COVID-19 predictive model used in LREP, which was later used in the entire country to predict all the waves. That was putting your neck on the line for the purposes of science. We at LREP Advisory Committee, we are very grateful. That is what
For me, I work with the C4 Society, an NGO called Young Professionals for Development. We are also members of ENET. My issue is very brief and to the point. You as media reporters, when you get a news item from a senior government official which is not factual or even false, for that matter, on the face value, without even having done the investigations, and then you hear it to the public, then there's great impact with that message or that communication. Then what is your role in terms of vetting such messages so that you don't mislead the public or the whole nation about an issue which you, from common sense, is really, really misleading? Thank you.
I'm the Senior Programs Officer, and I have two questions from the previous session and this session. The first one is, pandemics affect all the sectors in a country, and it is really sad that health was mentioned only once at the Africa Climate Summit, and looking at how can CSOs in all the sectors come together in pandemic response efforts, and do we think that CSOs in the different sectors can work together regarding pandemic response? Because when you look at pandemics, every sector was actually stopped. We couldn't do anything in all the sectors. So how do we come together to ensure that we are moving forward together, or basically what needs to be done so that we can work together and address the pandemic response? And the other question is on the media. So the media, Zainab touched on it a little bit. In my opinion, I believe the media needs to conduct investigations to ensure a story ends or is resolved. So why does this not happen, and what does the media need to do in this area? Basically ensuring that when a story comes up, it has an ending. We just don't see the start that there's a problem, and then so what happened? The problem came, so what happened? As in, what needs to be done in that area so that at least all these stories that come up have an end, like the COVID millionaires. So what happened?
Thank you very much. Zainab, I won't throw it to you. There's a request for someone to respond to her question on the CSOs. So I'll just ask you briefly, introduce yourself and respond.
Good afternoon, all. It has been a good day. My name is Ruth Barutumo from HENET. Bring civil society, international organizations, local organizations, FBOs and CBOs. As long as we're implementing a health project, we bring all of us together, and our main agenda is on advocacy of pertinent health issues. It is good that one of my colleagues in the previous panel talked about 3 things that civil society do, and one of them was evidence-based research. That is what we are getting into so that we can have evidence-based advocacy. We don't just talk about issues without having gone to the ground and scientifically collected information and picked out the issues. So my call to you is that, yes, please join us as Henet. We have done quite a bit of work with the bills that have been mentioned today. And as media, I would like to call upon you that, yes, you have invited us here, but continue engaging us as Henet, and we are going to be able to get some of these advocacy issues that have been.
Thank you very much. Zainab, I cross over to you.
I'd like to throw this question on seeing a story to the end to Kemi. There was a question, somebody asked a question about how follow-up of stories to ensure that you follow the story to the end. Media often reports and leaves the story hanging. You report the beginning, there's no middle, there's no end.
Well, following through to the end, I would admit, is really difficult for a number of reasons. And I think the true journalists on this panel already alluded to some of them. Sometimes your editorial board's interests is divergent from the story's angle. Sometimes it's also that there's a more trendy story that comes up that then means you divert your attention. Sometimes it's a function of how much capacity, how much resources you have within the newsroom to dedicate to those resources, and quite a few stories. And we're not very good at following up, to be honest. This is something we're becoming more intentional about doing, because when you follow up, there are two things that happen. One is you have a more informed public, but then also you get to record the impact of your work. So if you go back and cover that story and you find that something has changed. We do community reporting on primary healthcare services in Nigeria, for example. And primary healthcare is the responsibility of the subnational government in Nigeria. And this is something that some of the policymakers at the subnational level have called us out on. Have you gone back to these facilities? Have you gone back to check how those gaps that were identified have been breached? It requires intention and deliberateness about going back to follow the story through to the end. But also, I will put a caveat. This is health systems in Nigeria. This is PPPR in Nigeria. There's no end. It's a rabbit hole. You uncover this, and then there's something else to uncover, and something else to uncover. There is no end. Yeah.
Okay, then I think we can leave it at that point. I'm sure we'll still engage some more during tea. You can mark their faces and see where they stand when they go to take tea and ask them some more questions. Thank you very much. Thank you.
Check. Thank you very much. Let's appreciate them with a hand clap as they take their seats. Thank you very much. And it seems like there's need. It seems like we're the ones who also need to give insights on how we go about our work. Thank you very much. And ladies and gentlemen, thank you for being part of this and just being a great sports. I know there are some who may have wanted to contribute more, but in the interest of time, we're not able to accommodate that. But we could always find a way to engage even beyond this meeting room, this conference room. We can either begin, right during the time when taking tea, and during also give us an overview of what the day has been like and some of the take-home messages and insights. I'll now invite to the podium Pamela Stoney, who's our group managing editor at the Nation Media Group. Then we can take tea last. We can take tea as we go. Sorry? The mic stand, okay.
Good afternoon. Good afternoon. I know it's been a long day.
This will be easier.
I know it's been a long day, so I'll try to be really quick. It's 9 o'clock. It's almost 5 o'clock. But first of all, I want to thank you very much for honoring our invitation to come for this forum. And it's been pretty enlightening for me. I hope you've also learned something or gained something or shared some knowledge. I hope it wasn't in vain for you. So the aim of today's Nation Leadership Forum was to mobilize as we leave, what are the key things that we have acquired? I've really tried, but I may not have captured everything. I'll just speak on the few things that stood out as the panelists were speaking and as we had the question and answer interactions. I think the first thing we had is that while the dust has settled on COVID-19, we are still here with the statistics, and the statistics are still grim. 772 million confirmed cases, 6.9 million COVID-related deaths across the world. And then the next thing is, it's not a question of if we will have another pandemic, but when it will come. And then we learned that advancing pandemic preparedness and response in Africa really should be part of our public health agenda. And it must be recognized that no one entity can do it alone. It must involve everyone. It must involve civil society. It must involve the media, the experts here. And then there's recognition that a lot has gone towards preparing for the next pandemic. We heard about the first high-level meeting on pandemic preparedness and response. We also heard of the elevation of CDC as an autonomous public health agency, and this gives it a stronger mandate to drive its vision of a new public health order for the continent. We also heard that African countries must increase finances towards pandemic discussions about investment, and that in the new architecture, sharing of data will be mandatory. So we need to invest in data, but also to make sure that our data is secure. And we must be free, as Africans, we must be willing to do our research together. Then there's need to establish a platform that ensures equity and allows for tech transfer. Then we heard from the high-level panel that if the leadership is not right, if leadership doesn't work, then everything else is in vain, and that strategic leadership will check itself through evaluation, and we had the examples of what is happening in Uganda. We also heard that learn, adapt, and unlearn. And African governments must invest in healthcare workers and have them motivated. And this will help us to address the whole issue of brain drain. And we heard about Uganda doubling salaries for its health workers and how that has helped them to deal with the brain drain. And this applies not just to health workers, but also to our research experts. And then we heard about there's need, countries must invest in research. We have heard that Africa is still very far away from achieving the 2% that was committed in the Abuja Declaration to invest in health research and development. Then accelerating vaccination coverage faces several challenges, among them vaccine shortage, emerging health priorities, and changing priorities. And we heard about AMREF's strategy for accelerating the COVID-19 vaccination coverage, which includes health workforce capacity building, risk communication, and community engagement, integrating COVID-19 vaccine. Then we heard about the importance of preparedness and the case study from Israel, how Israel prepared ahead of time to roll out its vaccine, and within just a very short period had vaccinated 5% of its population. And then we need an Afrocentric approach to the vaccine rollout so that the vaccines that, as they're being designed and packaged, they're fit for Africa, unlike the situation where we had in the last pandemic. Then we need policies that bind pharmaceuticals who use Africa and Africans for vaccine trials to make those vaccines available to Africans. We need to work together as African countries. Also need to decolonize R&D so that it's our agenda that we are pursuing, as opposed to our researchers merely being used by Western firms to research on their behalf. We should target development of PPEs and not only vaccines. Governments should follow through commitments and go beyond declarations. We should promote local investment by encouraging private sector to invest through tax rebates and such incentives, rights. And then we heard about the role of civil society, bringing checks and balances and holding governments to account. And also bringing the voices of those who may not be able to speak directly to governments. And also civil society plays an important role in evidence generation. And then when it comes to the question of why should somebody care about a story, the media needs to think seriously about that. Tell more human interest, compelling stories that will make people care about the story. Focus beyond the problems and also look at where it's going well and bring those case studies also so that Africans can learn from each other. And the need for media collaboration across Africa is very clear because the media do not have all the resources to do their own. Lastly, somebody asked, what does the media need for the next pandemic? And the answer is better flow of information and access. Thank you.
Thank you very much, Pamela, for that well-explained brief or summary of what has been discussed across this conference and across the day in the course of this conference. And now I will just request you, in the event that, rather on your tables, there should be a QR code which has been printed and placed on your tables. So we request that you kindly scan the QR code on your tables so that it will lead you to a place where you can then give us of this kind. And we're looking forward to engaging with you beyond today. There's a lot, as you could see and hear, that we still have to address and we still have to put together so as to ensure that we are playing our part in this space of, as Zainab was asking, is it activism, advocacy, or journalism? We'll do what is good for the public. You can brand us later. We can brand us later. But thank you very much, and we shall definitely be, keeping your contacts and reaching out to you because of your expertise of the discussion. So at this point, it's safe to say that we have come to the close of our conference for today, for this Nation Leadership Forum. I'd like to thank each and every one of you for being part of it. I'd like to also thank the team that has been facilitating the online streams and the broadcasts. Our crew here, as well as those who are not visible here, but are somewhere within the vicinity. Let's appreciate them, ladies and gentlemen. And let's appreciate yourselves. Let's appreciate you. It will wake you up then. So when you're outside there, you start clapping, we'll be grateful all the same. So thank you very much for being part of this, and we look forward to more engagements. My name is Dan Monge. I have been your MC across the day on behalf of my other co-pilots on this flight. That is Helen Aura and Zena Bondati. Thank you very much. Have yourselves a great evening. Coffee is served and biting. I had someone saying, I hope there's cake. I hope so too. Have yourselves a great evening. God bless.